world-class healthcare products and services. This prompted Emma Pharma to construct its business on the triad of our people, our partners, and our technology.
What do we know about the inside of a machine? And what do we know about the inside of a human body? What is hiding behind a diagnostics test? I'll tell you, more than you ever imagined. Think how complicated it is to replicate the same process that happens in nature when a small molecule such as 125 vitamin D has to be identified among a million of the same molecules. You have to clone the 125 vitamin D receptor and send it on a hunt through plasma for its target, the 125 vitamin D. Once the target is identified, a very special monoclonal antibody has to be engineered with the ability to bind this 125 vitamin D with complex receptor. Just the complex receptor though, not the free-floating receptor. In order to achieve this, the understanding of biology is essential in reproducing what nature has mastered through millions of years of evolution.
world-class healthcare products and services. This prompted Emma Pharma to construct its business on the triad of our people, our partners, and our technology.
What do we know about the inside of a machine? And what do we know about the inside of a human body? What is hiding behind a diagnostics test? I'll tell you, more than you ever imagined. Think how complicated it is to replicate the same process that happens in nature when a small molecule such as 125 vitamin D has to be identified among a million of the same molecules. You have to clone the 125 vitamin D receptor and send it on a hunt through plasma for its target, the 125 vitamin D. Once the target is identified, a very special monoclonal antibody has to be engineered with the ability to bind this 125 vitamin D with complex receptor. Just the complex receptor though, not the free-floating receptor. In order to achieve this, the understanding of biology is essential in reproducing what nature has mastered through millions of years of evolution.
world-class healthcare products and services. This prompted Emma Pharma to construct its business on the triad of our people, our partners, and our technology. world-class healthcare products and services. This prompted Emma Pharma to construct its business on the triad of our people, our partners, and our technology.
What do we know about the inside of a machine? And what do we know about the inside of a human body? What is hiding behind a diagnostics test? I'll tell you, more than you ever imagined. Think how complicated it is to replicate the same process that happens in nature when a small molecule such as 125 vitamin D has to be identified among a million of the same molecules. You have to clone the 125 vitamin D receptor and send it on a hunt through plasma for its target, the 125 vitamin D. Once the target is identified, a very special monoclonal antibody has to be engineered with the ability to bind this 125 vitamin D with complex receptor. Just the complex receptor though, not the free-floating receptor. In order to achieve this, the understanding of biology is essential in reproducing what nature has mastered through millions of years of evolution.
The Medical Laboratory Science program organized by the College of Chemical Pathologists of Sri Lanka. To begin the program, our first speech of the today's program will be on Keep Your Bones Strong with Calcium and Vitamin D by Dr. Nange Kularatnam, Consultant Chemical Pathologist at District General Hospital, Kalutara. May I kindly invite Dr. Nange Kularatnam to deliver her speech.
Good morning. My topic is Keep Your Bones Strong with Calcium and Vitamin D. This is the outline of my presentation. The skeletal system is the foundation of our body. Bone helps in movements. It protects internal organs and acts as a reserve for minerals, especially calcium and phosphate. Bone is composed of extracellular mineralized matrix with a smaller cellular fraction. So in this picture, you can see osteoblast, the bone forming cells at the base, then the organic matrix. 90% of the matrix is composed of type 1 collagen. Then the mineralization of the matrix occurs due to the deposition of calcium and phosphate as hydroxyapatite. In the mature bone, there is continuous remodeling occur. It involves bone resorption followed by new bone formation. Bone resorption is mediated by osteoclasts, which are multinucleated cells. Then this bone is replaced by osteoblast. So in adults, at any one time, 10% of the bone mass is subject to remodeling. This leads to repair the damage and strengthen the bone. Bone growth and turnover are influenced by the metabolism of calcium, phosphate, magnesium, and few hormones, especially parathyroid hormone and calcitriol, which is also known as 1,25-dihydroxy vitamin D. Calcium and vitamin D work together to protect bones. Calcium is necessary to build the bones and to keep them healthy. The daily requirement of calcium depends on age and sex. So the minimum daily requirement for an adult is about 1000 milligram per day. The average human body contains 1 kilogram of calcium, of which 99% is present in the skeletal system. Vitamin D helps the body to absorb calcium effectively. The daily requirement of vitamin D for an adult is about 400 to 800 international units per day. In the plasma, calcium exists in 3 physiological states. 50% of the calcium found as ionized calcium. 41% binds with plasma proteins, mainly albumin. The rest 9% is complexed with small anions. The biologically active form of calcium is ionized calcium. Therefore, its concentration is tightly regulated by parathyroid hormone, calcitriol, and calcitonin. Calcium binding to the albumin, so calcium binds to the negatively charged sides of the albumin, therefore its binding is pH dependent. So in acidosis, there will be less negative charge and less binding, which leads to increased ionized calcium concentration. In alkalosis, there will be more negative charge, more binding, so the ionized calcium concentration is decreased. For each 0.1 unit change in pH, approximately 0.05 millimole per liter, that is 0.2 milligram per deciliter, inverse change occur in ionized calcium. For example, if the pH is increased by 0.1 unit, then the ionized calcium concentration will be decreased by 0.05 millimole per liter. Changes in the plasma albumin concentration will affect the concentration of total calcium, which in turn causes misinterpretation of the calcium results. At physiological pH, 1 gram per deciliter of albumin binds with 0.8 milligram per deciliter of calcium. So hypoalbuminemia reduces total calcium level, whereas hyperalbuminemia increases total calcium levels. So here I have given two equations. So this will help us to calculate the expected calcium concentration if the plasma albumin concentration is normal. So the first equation, if you are measuring your calcium levels in millimole per liter, you can use the first equation. And if you are measuring the calcium concentration in milligram per deciliter, you can use the second equation. So the calcium homeostasis. So as I said earlier, the calcium concentration in the plasma is tightly regulated. So there are calcium sensing receptors in the parathyroid gland. There are 4 parathyroid glands embedded in the thyroid gland, which is situated in the neck. So these calcium sensing receptors, they sense low calcium. So they stimulate the parathyroid gland and it secretes parathyroid hormone. Parathyroid hormone stimulate the formation of calcitriol, that is 1,25-dihydroxycholecalciferol, which stimulate the absorption of calcium and phosphate from the gut. At the same time, parathyroid hormone also acts on the renal tubules and causes increased calcium resorption. And in high concentration, it causes bone resorption. All these will increase the plasma calcium concentration and normalizes the calcium level. So few things about the vitamin D metabolism. When the 7-dehydrocholesterol in the skin is exposed to sunlight, it will convert it to cholecalciferol. So that is vitamin D3. So from the diet also we are taking vitamin D. So all these vitamin 3 will undergo hydroxylation in the liver followed by kidney and form 1,25-dihydroxy vitamin D3. So that is calcitriol. This will help to maintain the calcium balance in our body. So again, as I said, these 25-hydroxycholecalciferol undergo 1-alpha hydroxylation in the kidney to produce calcitriol. Calcitriol acts on the gut and stimulate the absorption of calcium and phosphate. And in the bones, it causes osteoclastic resorption and releases calcium and phosphate into the extracellular fluid. So when the calcitriol concentration is increases, it negatively inhibits its formation. Now we'll look into the causes of hypocalcemia. So the main cause is, the common cause is hypoalbuminemia. So I explained this earlier. So in hypoalbuminemia, binding of the calcium also less, so it will cause hypocalcemia. Then the chronic renal failure. So 1-alpha hydroxylation occurs in the kidney. So in renal failure, that will affect it, and the calcitriol formation is affected. So the calcium absorption will be affected. Then the magnesium deficiency. Magnesium is important to secrete parathyroid hormone as well as the action of parathyroid hormone. So in case of magnesium deficiency, the synthesis of parathyroid hormone is affected and calcium absorption will be affected. hypoparathyroidism. So again, the parathyroid hormone secretion is affected. In vitamin D deficiency, so the calcitriol is important. It plays the main role in the calcium homeostasis. So in vitamin D deficiency, the calcitriol formation will be affected. Anticonvulsant treatment. Certain anticonvulsant will affect the metabolism of vitamin D. So that will cause hypocalcemia. Acute pancreatitis. So in acute pancreatitis, calcium is precipitated as soap, so that will lead to hypocalcemia. Acute rhabdomyolysis. Due to the cell lysis, the phosphate concentration will be high. It combined with calcium and precipitated as calcium phosphate. So the causes of vitamin D deficiency include inadequate exposure to sunlight, inadequate dietary vitamin D malabsorption, severe hepatocellular disease. So as I said earlier, the 25-hydroxylation occurs in the liver. So in severe hepatic disease, that will be affected. Then the renal failure and anticonvulsant therapy. Vitamin D deficiency causes rickets in children and osteomalacia in adults. So here you can see the skeletal deformities in both of these conditions. So how can we prevent vitamin D deficiency? Though the Sri Lanka is a country we are getting adequate sunlight throughout the year, but the prevalence of vitamin D deficiency is high. So how can we prevent this? So for that you need adequate sun exposure. So it is recommended to expose to sun at least 3 times a week during the daylight, that is between 10 a.m. to 3 p.m. on 20 to 30% of the body surface area. That includes forearms, hands and lower legs for about 30 minutes per session. So you have to expose to 30 minutes 3 times a week between 10 a.m. to 3 p.m. on 20 to 30% of the body surface area. So now I am going to tell few things about the measurement of total calcium, ionized calcium, parathyroid hormone and vitamin D. So in the measurement of total calcium, the pre-analytical issues include the blood, the serum or heparinized plasma are the preferred specimen. So if you are using serum, the blood should be collected in acid wash or new plain tube to prevent contamination. Citrate, oxalate and EDTA anticoagulant should not be used. And if you are measuring total calcium, you have to avoid the application of tourniquet, because the tourniquet causes venous stasis and that will increase the protein concentration and it will give high calcium concentration. But if you are practiced to give the adjusted calcium or corrected calcium, the tourniquet can be applied. Measurement of ionized calcium is indicated in critically ill patients, patients with high concentration of globulin and in acid-base disorders. So as we discussed earlier, the ionized calcium concentration depends on pH. So therefore, we have to take certain precautions to avoid pH changes. So patient must relax and breathe normally for at least 10 minutes. Heparinized whole blood or serum can be used. Whole blood specimen should be analyzed within 15 to 30 minutes or chill the specimen in an ice water slurry to prevent metabolic changes. Serum specimen should be collected in evacuated gel tubes and tubes should be filled completely and centrifuged to form an effective barrier. Measurement of intact PTH. So you can collect the blood either in the EDTA tube or a plain tube. So the plasma or serum should be separated as early as possible, ideally in a refrigerated centrifuge. Then if the analysis is delayed, the plasma or serum should be stored frozen. Then the measurement of vitamin D. Serum or plasma can be used And if you want to transport the serum or plasma, that should be in 2 to 8 degrees C. For the prolonged storage, you have to keep it at minus 20 degrees C. So here I have given the target values for the vitamin D deficient, insufficient and sufficient levels in both units, nanogram per milliliter and nanomole per liter. So now I am going to discuss two cases. My first case is a 40-year-old lady presented with cramps of both hands. She underwent gastric bypass surgery 6 months ago and thyroidectomy 10 years back. The initial investigations revealed hypocalcemia and hyperphosphatemia. The adjusted calcium levels are also low. So what could be the differential diagnosis? Low calcium, high phosphate, and with the history of bypass surgery and thyroidectomy. So there are possibilities of, due to the bypass surgery, she can get malabsorption, and due to the thyroidectomy, she may have hypoparathyroidism. So the differential diagnosis would be vitamin D deficiency due to malabsorption or hypoparathyroidism. Further investigations revealed normal magnesium, normal vitamin D, and her plasma intact PTH was low. So the diagnosis will be hypoparathyroidism. Second case is a 75-year-old widow presented with pins and needles around her mouth and twitching of her facial muscles. She lived alone and had poor dietary habit. Initial investigations show low calcium, low phosphate, and increased alkaline phosphatase activity. The adjusted calcium is also low. So the differential diagnosis, when we are considering the history and investigations, both calcium and phosphate are low, high alkaline phosphatase activity, and she lives alone and had a history of poor diet. So the differential diagnosis could be vitamin D deficiency or magnesium deficiency. So the serum magnesium levels were normal, and vitamin D, she had very low vitamin D level. So the diagnosis is vitamin D deficiency. Here in the chart I have shown the biochemical features of the various types of hypocalcemia. So in hypoparathyroidism, so you all know in hypoparathyroidism the PTH level will be low, and the parathyroid hormone has a phosphatoric effect. So in the absence of, with less parathyroid PTH level, the serum phosphate will be elevated, and the creatinine and alkaline phosphatase are normal. In vitamin D deficiency, vitamin D absorb both calcium and phosphate from the gut. So in vitamin D deficiency, phosphate level will be low, creatinine normal. So that low hypocalcemia stimulate the parathyroid gland and causes increased PTH secretion. So the PTH will be high and alkaline phosphatase also high. In renal failure, here the creatinine is high, then due to the kidney is unable to excrete the phosphate, so the phosphate level will be high. Again, low calcium will stimulate the parathyroid and causes secondary hypoparathyroidism. So the hyperparathyroidism, so the plasma PTH concentration is increased and alkaline phosphatase also increased. So in summary, calcium and vitamin D are the dynamic duo for bone health. Calcium is the mineral that makes the bone strong, and calcium needs vitamin D to absorb it into the body. The commonest cause of hypocalcemia is hypoalbuminemia. To correct this, calculate the serum albumin adjusted calcium concentration to confirm hypocalcemia. The first line investigation of hypocalcemia are serum phosphate, magnesium, creatinine, electrolytes, and alkaline phosphatase. Second line investigations include vitamin D and parathyroid hormone. Thank you.
Thank you, madam. The floor is open now for any questions. You can type your questions and send us online. In that case, let me ask one question, madam. In sample collection in serum PTH, plasma PTH, is this centrifugation, refrigerator centrifuge, is that a must or?
No.
Right.
It's recommended to
Yeah.
use it as a refrigerator centrifuge, but in my lab I am using the normal centrifuge.
Okay,
And
okay.
yeah, our results are good.
Right, right. In the absence of any questions, any other questions, we can wind up the session now. May I now invite Dr. Dulani Javardhana, consultant chemical pathologist, to present the token of appreciation to Dr. Nange Kularatna.
Thank you, madam. We have a special announcement to make. All the participants are kindly requested to visit the virtual industrial exhibition using a laptop and stand a chance to win 3 Samsung Galaxy A7 tablets. What you all have to do is go to the virtual trade expo and visit the virtual stalls today until 10:30 p.m. and you have to go to drop card link in the stall and click submit your details. Then your virtual passport will be automatically stamped with the exhibitor's logo. Only the completed passports will be selected for a raffle draw and the 3 lucky winners will be selected. So for more details, you can refer to the back page of the abstract book. And in the lineup, we have the tea break now. Let us break for tea, and we hope to join with you again by 10 a.m. Thank you.
world-class healthcare products and services. This prompted Emma Pharma to construct its business on the triad of our people, our partners, and our technology.
What do we know about the inside of a machine? And what do we know about the inside of a human body? What is hiding behind a diagnostics test? I'll tell you, more than you ever imagined. Think how complicated it is to replicate the same process that happens in nature when a small molecule such as 125 vitamin D has to be identified among a million of the same molecules. You have to clone the 125 vitamin D receptor and send it on a hunt through plasma for its target, the 125 vitamin D. Once the target is identified, a very special monoclonal antibody has to be engineered with the ability to bind this 125 vitamin D with complex receptor. Just the complex receptor though, not the free-floating receptor. In order to achieve this, the understanding of biology is essential in reproducing what nature has mastered through millions of years of evolution.
world-class healthcare products and services. This prompted Emma Pharma to construct its business on the triad of our people, our partners, and our technology.
We warmly welcome you back. Our next speech is on serum protein electrophoresis, Essentials to Know by Dr. Thamara Herath, Consultant Chemical Pathologist at Medical Research Institute, Colombo. May I kindly invite Dr. Thamara Herath to deliver her speech.
Good morning. Thank you for the kind words of introduction. And my topic today is on serum protein electrophoresis. In the next 25 minutes or so, I am going to discuss this topic Under these subheadings, what is serum protein electrophoresis, how it works, evaluation of serum protein electrophoresis, and its clinical uses. Electrophoresis is the migration of charged solutes or particles of any size in a liquid medium under the influence of an electrical field. The separation depends on the size, shape, and charge of proteins. This is a diagram of a gel protein electrophoresis. Serum is placed in a buffered liquid medium with a pH of 8.6. An electric charge is applied, then the charged particles are migrated in the liquid medium under the influence of electrical field. At this alkaline pH, proteins are negatively charged, so they move towards the anode. The rate of separation depends on the size, shape, and net charge of proteins. In a semi-automated gel electrophoresis system, the steps included are sample application, electrophoretic migration, drying, staining, and final drying. Only manual step is handling samples and the gel. The other technique used in measuring serum protein electrophoresis is capillary electrophoresis. It depends on two main principles of separation. The first, alkaline pH, which was created by a strong electroosmotic flow. The electroosmotic flow is overall fluid movement of positively charged buffer ions carrying fluid towards the cathode. The second, electrophoretic migration of the individual proteins, is based on their charge to mass ratio at specific voltage, electrolyte composition, and pH conditions. So this is a diagram of a capillary electrophoresis. You can see a high voltage is applied between these two electrodes, and there's a capillary tube through which the serum sample is passed through. The sample is entered at the anodic end, and because of the electroosmotic flow, the proteins are migrated towards the cathode. So a deuterium lamp is placed here, and with the help of a detector, each protein fraction is measured. This is a cross section of a capillary This is a cross section of a capillary tube in capillary electrophoresis. You can see these orange color dots. They are positive charges of the buffer solution, and there are negative charges of capillary wall. Serum is injected at the anodic end. Then, since the electroosmotic flow is a stronger force than the electrical field, all proteins are carried towards the cathodic end of the capillary. So the detection of proteins is done at the cathodic end. Capillary electrophoresis is based on the electrokinetic separation of proteins in a capillary filled with electrolyte buffer. The combination of small capillary internal diameter of less than 100 micrometers, very high voltage, and tight temperature control allows fast, highly efficient separation of proteins, excellent resolution, and reproducibility. Let's move on to evaluation of serum protein electrophoresis. There are two ways. One is qualitative evaluation with standards, and the other one is quantitative evaluation with densitometry. In serum protein electrophoresis, serum proteins are separated into 6 main groups, namely albumin, alpha 1 globulins, alpha 2 globulins, beta 1, beta 2, and gamma globulins. So, what are the major components of globulin bands? Alpha 1 globulins consist of mainly alpha 1 antitrypsin, and alpha 2 globulins include haptoglobin, alpha 2 macroglobulin, and HDL. Beta globulins include transferrin, LDL, and C3 complements. Immunoglobulins form the majority of gamma globulins, and in acute inflammation, if the C-reactive protein levels are high, they also appear in gamma globulin region. The same thing in an electrophoretogram when you see in capillary electrophoresis. So this is the normal pattern of serum protein electrophoresis. You can see albumin followed by alpha 1, alpha 2, beta, and gamma globulins. So let's see qualitative evaluation by comparison with the standard. So this is a normal control. You can see the top end, the normal albumin band followed by alpha 1, alpha 2, beta, and gamma globulins. You can see gamma globulins looks as a diffuse band rather than a discrete band. Here you can see compared to normal control, albumin is reduced and there is almost no gamma globulins. So there is reduced albumin and markedly low immunoglobulins. The third one, compared to normal control, is a normal serum protein electrophoresis. The fourth one, you can see there's an abnormal band in gamma region. The fourth, there's a polyclonal increase of gamma globulins. Here, compared to the compared to the fourth one, where there you can see a discrete band in gamma globulin, but in the line 8, there's a diffuse increase of gamma globulins. We call it polyclonal increase in immunoglobulins. Evaluation of separated protein fractions, that is quantitative evaluation with densitometry. The strain gel is passed through a densitometer. A densitometer is a special spectrophotometer that measures light transmitted through transparent but stained gel. So we take the absorbance. The densitometer converts the bands into peaks. So each of these bands are converted into corresponding peaks by the densitometer. The same thing in a more closer view. A microprocessor evaluates the area under each peak and reports each as a % of the total sample. When the concentration of total protein is entered, the concentration of each band is calculated. Therefore, we can apply this formula, that is concentration of each peak equals total protein into percentage of area under the peak. So let's see these two examples. So in the first one, we entered total protein as 7 grams per deciliter, and the percent area under albumin peak is 69.9%. So 7 into 69.9% equals 4.9 grams per deciliter. Similarly, total protein into percent area under albumin peak, gives albumin concentration of 3.5 grams per deciliter. Densitometry has more advantages. In this blue shaded area, you can see a typical normal electrophotogram. The light green area behind that gives a typical electrophotogram seen in multiple myeloma. Quantification of a monoclonal immunoglobulin on serum protein electrophoresis. Peak quantitation on protein electrophoretic curve is not very accurate and not precise. It's an estimate only. It requires accurate total protein measurement and accurate determination of the peak. Therefore, it is important to quantify using same technique in the same lab. There are several ways of quantifying monoclonal immunoglobulin. This is called from top to bottom. From top to bottom. And this is called from valley to valley. This is a drop method. And this is tangent skimming. Let's move on to clinical uses of electrophoresis. The main and the commonest usefulness in the diagnosis is the diagnosis and management of multiple myeloma, and there are many other uses as well. So first we'll look into multiple myeloma. It is characterized by the neoplastic proliferation of a single clone of plasma cells producing a monoclonal immunoglobulin. So in this slide you can see abnormal plasma cells in a bone marrow aspirate. Diagnosis of multiple myeloma. This is according to the International Myeloma Working Group guidelines. The criteria for the diagnosis of multiple myeloma. In these first two criteria must be met to diagnose multiple myeloma. First one is clonal bone marrow plasma cells equal or more than 10% or Borneo extramedullary plasmacytoma confirmed by biopsy, plus one or more of the following myeloma defining events. So these 7 criteria are myeloma defining events. The patient should have the first criterion plus one or more of these myeloma defining events. So out of these 7, first 4 indicate end organ damage. High calcium, renal insufficiency, anemia and bone lesions. We usually call them CRAB criteria. So we'll see one by one. Hypercalcemia, that is serum calcium level of more than 0.25 millimoles per liter higher than the upper limit of normal, or absolute total serum calcium should be more than 2.75 millimoles per liter. Renal insufficiency as indicated by serum creatinine of more than 177 micromoles per liter or creatinine clearance less than 40 milliliters per minute. Anemia, that is hemoglobin should be less than 10 grams per deciliter or more than 2 grams per deciliter below the lower limit of normal. Bone lesions, there should be one or more osteolytic lesions on skeletal radiography, CT or PET-CT. Then there are biomarkers of malignancy. These include clonal bone marrow plasma cells of equal or more than 60%, serum free light chain ratio involved to uninvolved equal or more than 100, and one or more focal lesions of 5 millimeter or more on MRI scans. Serum protein electrophoresis in multiple myeloma. You can see these two electrophoresis. A is the normal control. Compared to that, B is the sample of a patient with multiple myeloma. So compared to normal control, here there is hypoalbuminemia and there's a monoclonal component in gamma globulin region. In addition to that, there's reduction in normal gamma globulins. We called it immunoparesis. So, in addition to monoclonal component, there is hypoalbuminemia and immunoparesis. So, when we look at the electrophotogram after densitometric scanning, this monoclonal immunoglobulin can be seen as a spike. So let's see some of the monoclonal peaks as seen in capillary electrophoresis. This is a monoclonal peak in gamma globulin region, monoclonal peak in beta 1 region, monoclonal peak in beta 2. If beta 2 globulins equal or more than beta 1 globulins without inflammatory response or hepatic disease, we have to perform an immunotyping for a monoclonal immunoglobulin. So if we perform gel electrophoresis, we have to go for immunofixation. Monoclonal immunoglobulin in alpha 2 zone. If patient's alpha 2 value is more than reference alpha 2 value without inflammatory response, then again we have to perform an immunotyping for a monoclonal immunoglobulin. Types of monoclonal proteins in multiple myeloma based on immunoglobulin isotypes with frequency parallel to normal serum percentages. These are the frequency order. The highest is the IgG kappa or lambda, then IgA kappa or lambda, then free kappa or lambda. These are called Bence-Jones proteins, and there are IgM, IgD and IgE, which are very rare, and the frequency is less than 1%. These are the proposed recommendations for quantification of gamma migrating serum paraproteins and recommended by the joint working group on this quantification of monoclonal bands in Australia and New Zealand. So, gamma migrating serum paraproteins should be quantified by densitometric or capillary zone electrophoresis measurement in grams per liter rounded to the nearest whole number. Paraproteins less than 1 grams per liter should be referred to as less than 1 grams per liter or trace with comments such as small band cannot be quantified reliably. Paraproteins visible only by immunofixation should be described in the comment section. For example, IgG kappa paraprotein only visible by immunofixation rather than being given a quantified value. The perpendicular drop method for quantification is proposed for gating of gamma region paraproteins. For a paraprotein in the non-gamma regions, the beta region being the most common for IgA paraproteins, report as total protein in the beta region. That is total protein plus paraprotein quantification at presentation and during monitoring. The report should include a comment identifying the paraprotein as migrating in the beta region and stating that the concentration includes normal beta proteins. Attempts to provide an estimate of the true paraprotein concentration by subtracting a predetermined level for other beta proteins are not recommended. So here non-gamma paraprotein in the non-gamma regions usually we get those in beta region. We have to quantify total protein in the beta region, that is total beta plus paraprotein. Monoclonal band in serum protein electrophoresis. If we see a monoclonal band in serum protein electrophoresis in a symptomatic patient, most of the time it is due to multiple myeloma, but there can be other causes as well, like Waldenström's disease, where the major immunoglobulin type is IgM, and there are non-Hodgkin's lymphoma and chronic lymphoid leukemia. In asymptomatic patient, if we see a monoclonal band in serum protein electrophoresis, that can be due to smoldering myeloma or monoclonal gammopathies of undetermined significance, that is called MGUS. Then there are oligoclonal bands in serum protein electrophoresis as well. That is presence of multiple faint peaks. This profile is observed in autoimmune diseases like rheumatoid arthritis, Sjogren syndrome, and lupus erythematosus. Also in infectious diseases like viral, bacterial, or parasitic. Then there are autoimmune reactions that show these oligoclonal bands. For example, patients with transplants or patients under immunosuppressive treatment. Then there are some diseases that give characteristic patterns in serum protein electrophoresis. Let's see one by one. In nephrotic syndrome, you can see hypoalbuminemia and elevated alpha-2 globulins. This is due to increased production of alpha-2 macroglobulins, and there is hypogammaglobulinemia. In acute inflammation, albumin is near normal and there is elevated alpha-2 globulins. In chronic inflammation, albumin can be normal or low and there is elevated alpha-1 and alpha-2 globulins. And also there is polyclonal increase in gamma globulins. Hypogammaglobulinemia, that is, there is the gamma globulins are decreased. So the causes include immunodeficiency, immunosuppressive treatment, and free light chain disease. This is a cirrhotic profile. You can see a decrease of albumin, alpha-1 and alpha-2 globulins. These are due to hepatocellular insufficiency. And there is a polyclonal increase of beta-gamma globulins. So this is due to polyclonal increase of IgA in beta-2 and IgG in gamma. Usually, in a normal electrophoretrogram, you can see beta-2 globulins coming as a peak and then going down to the base, and then gamma globulins appear. Instead of that, you can see here beta and gamma globulins are bridged, which is characteristic of a cirrhotic profile. This is an electrophoretogram of hemolyzed serum. You can see increased alpha-2 globulins due to the presence of hemoglobin haptoglobin complexes, and beta-1 globulins are increased due to free hemoglobin. This is plasma or serum with fibrinogen residues. So fibrinogen can be seen in beta-2 region. Here in acute inflammation, if the C-reactive protein level is more than 200 milligrams per liter, it gives a small distortion in gamma depending on polyclonal background. Here you can see albumin peak is somewhat bifurcated. The possible causes include bisalbuminemia due to genetic mutation, or it can be due to interference. by lipoproteins, biliary pigments, drugs like antibiotics, and products of contrast for X-ray. Here again you can see there's an albumin peak, and adjoining that there's a small peak. This is due to interference in albumin zone by lipoproteins, biliary pigments, drug interference like antibiotics, and products of contrast for X-ray. This is a heterozygous phenotype of alpha-1 antitrypsin. Usually you get, in a normal electrophotogram, you see alpha-1 globulin as a single peak. But here you can see double peaks. So these are my references. Thank you.
Thank you, madam, for that very informative lecture. Now the floor is open for questions. If you have any questions, you can go to the Q&A portal and type them down so we can ask from the speaker.
Presentation. Yeah, thank you, Tamara, for giving a nice presentation. I learned a lot today. So I have only one question because I am learning. So according to your CREP criteria or something you said?
Yes.
And there's another one at the bottom.
Yes.
That also says plasma, clonal cells.
Yes.
Are they the same or different, Tamara?
Here, these three are newly included in the in the diagnosis of multiple myeloma. Myeloma defining events.
Yeah.
So earlier there was 4 criteria.
So the
that
first
is CREP.
criteria,
First
Tamara?
4.
Yeah.
Those indicate end organ damage.
Yeah.
Then there are biomarkers of multiple myeloma. These include, because the plasma cells here is more than 60%, equal or more than 60%, like that. And free light chain, again, recently coming into play. And the involved to uninvolved.
No, not that, Tamara. The first at the beginning you said plasma cells should be more than 10%.
Yes, yes.
And again another criteria, the bottom one says plasma clonal
Yes.
cells more than 60%. So wonder why the same is appearing twice.
That is why I think, madam, this is because of the amount. The percentage is very much high in the
latter one.
Latter one.
Okay.
So it's according to the guidelines, it's the first one. It should be there,
Yeah, right.
but
If the other one is
together
less,
with that, out of 7 I mentioned, there should be 1 or more.
okay, right.
So if the first is more than 10%, again, if it is more than 60%, it comes as
It's one criteria then.
yes.
So
No,
they-
in that case, according to this,
that's a
yes,
reason.
according to this, the diagnosis is multiple myeloma because first one together with one of these 7.
But it's the same, but the amount is more.
Yes, the amount is more. That's why.
Okay, right. Thank you so much.
Thank you.
Thank you, madam. Since there are no questions in the system, I would like to wind up the session. I kindly request Dr. Eresha Jasing on stage to hand over the token of appreciation to the speaker. Thank you, madam.
Chromatography is an analytical technique we used to separate a mixture, and our next speaker will speak to us about the chromatographic methods. May I now invite Dr. D.N. Senanayaka, consultant chemical pathologist at District General Hospital, Trincomalee, to deliver her speech.
Thank you very much, Saraji, for your kind introduction. Welcome you all to my lecture today, chromatographic techniques. As you know, chromatography is a separation method used to separate mixture of analytes or liquid from that we used that we taken from the patient samples. This is a separation technique such as we use in distillation, such as simple distillation or fractional distillation or steam distillation. In day-to-day life, we use sieving for separation. Some seeds from the other unwanted particles. So like that, chromatography also a separation technique. Here I'm going to discuss about the basic principles of the chromatographic techniques and the types of chromatographic techniques that we use in the laboratory. In chromatography, there are two phases, namely stationary phase and the mobile phase. The stationary phase is the phase that is either a solid or a liquid particle which is attached to a glass or a metal surface on which the component of the mixture to be separated is absorbed selectively. In the mobile phase, usually in our laboratory should be a patient sample such as blood, CSF or urine, and it is a phase that is either liquid or gas that is passed through the chromatography system where the components of the mixture are separated at different rates by absorbing them into the stationary phase. This is a basic graphical description of the chromatography. As you know, the rounded particles are the stationary phase and the mobile phase are the green and blue particles. These blue and green particles will be absorbed selectively to the rounded stationary phase, and then we'll elute them using different buffers. There are 14 types of chromatography techniques. I'm going to discuss the basic principles of the chromatography techniques of these 14 types, namely affinity chromatography, anion exchange chromatography, cation exchange chromatography, column chromatography, flash chromatography, gas chromatography, and gel filtration. Also, there's high performance liquid chromatography, as you all know. You are very familiar with the HPLC. And hydrophobic interaction chromatography, ion exchange chromatography, liquid chromatography, paper, reverse phase, and thin layer chromatography. We'll first move on to affinity chromatography. Components of a mixture that we are using are separated when the element having an affinity towards the stationary phase. It will bind to the stationary phase. Other components are eluted with the mobile phase. So the component that we are interested now are bounded to the stationary phase. The components which are attached to the stationary phase are eluted by exchange in the pH or change in the ionic strength or other conditions. This is a graphically describing this affinity chromatography. Here the red particles only binds to the solid phase, and the other green, yellow and purple particles will elute with the mobile phase. But by changing the pH or the buffer, we can elute the particular red particle that we are interested lately, and then we can measure it by using other techniques. Anion exchange chromatography, it is based on the principle of attraction of positively charged resin and the negatively charged analyte. Stationary phase is the first coated with positively charged, where the components of the mixture with the negative charges will be bind. Then we'll remove those anion by using different buffers. So we are using this one to separate only anions, so we have named it as anion exchange chromatography. Here you can see it clearly, where the positive ions or the cations are removed with the mobile phase, but the anions are bounded to the stationary phase. And later when we change the buffer, those bounded anions will also eluted with the mobile phase. And then the cation exchange chromatography. Here we use a negatively charged resin to bind the positively charged analyte. So same as the above earlier, we will separate the positively charged analyte which we are interested, and we are removing the negative charge analytes with the mobile phase, and then we'll change the buffer and then remove the cations and then measure it. So from this we can measure the positively charged anions, and so we are calling it cation exchange chromatography. In column chromatography, this is based on the principle of different absorption, where different molecules in a mixture have different affinities with the absorbent present in the stationary phase. So depending on the stationary phase, absorbance of the stationary phase, we can change the affinity of the molecule. The molecules having higher affinity remain absorbed for a longer time and decreasing. They will not move with the mobile phase. They will absorb to the stationary phase and stay there. But the other molecules will move with the mobile phase. However, the molecules with the low affinity move with the faster movement, and we will be able to separate the analyte that we are interested. Here you can see the first diagram. We can see the light green color loaded sample, and then with the time, the stronger interaction yellow color analyte will be bound to the stationary phase, and it will move very slowly, whereas the weaker interaction analytes will move faster and they will elute first. Later on, the analyte which are interested, the yellow one, will remove. So we can measure and separate those analytes that we are interested in. In flash chromatography, it is similar to that of column chromatography, but we are using pressurized gas that will make the process faster and more efficient. This will decrease the turnaround time of the sample and the test. Molecules bind to the stationary phase on the basis of their affinity, while the rest of the solvent is eluted out by applying the pressured gas, which quickens the process. Here is the graphical in description about that. We are using nitrogen gas since it is non-reactive with most of the analytes. We are using nitrogen gas as the to pressurize the sample. In gas chromatography, here it is based on the principle that components having a higher affinity to the stationary phase have a higher retention time as they take a longer time to come out of the column. However, the components having higher affinity to the stationary phase have less retention time as they move along with the mobile phase. So the mobile phase is a gas and it is mostly helium. We are using helium because it is an inert gas. As you know, it is in the 8th group of the periodic table. It is an inert gas and it does not react with the other elements. And it carries the sample through the column. So the analyte, what we are interested with, will not have any interferences or the reaction with the helium gas that we are using here. The sample, once injected converted to the vapor stage, is then passed through the detector to determine the retention time. The components are collected separately as they come out of the stationary phase at different times. Here is the description here. As you can see, there is a oven where the injected port is covered with, so that the sample is evaporated and it is in the gaseous state. So it goes through the column with the gas flow, which is helium, and then goes through the detector, and then we can analyze the data. This is molecular sieve chromatography. Molecules are partitioned between mobile phase and the stationary phase as a function of their relative sizes. There are small particles as well as bigger particles in the sample. As you know, prealbumin is a very small particle, whereas a globulin is a very large particle. So if we can separate those particles using their sizes, it is called the molecular sieving chromatography. Like we are sieving flour in our day-to-day life, we separate the larger particles from the powdered particles. The same that we are using here, the same principle we are using here. In the stationary phase, there is a mixture of porous polymer which have a pores of specific sizes. If we want to separate the smaller particle, we should have a smaller pores matrix. And if we want to separate bigger particles, we should have a bigger porous polymer. Likewise, we can change the matrix and we can decide what we are going to separate. When the sample is injected with the mobile phase occupies the pores of the stationary phase. That means here you can see big blue and light blue particles and smaller ash particles. Here we have separated the light blue particle like that. If the size of the molecule is appropriate enough to enter the pores, they remain in the pores partly or fully. Like this, the light blue particles remain in the pores, while the big blue and the ash particles will remove. But the ash particles are very small. It goes inside the pores, so it will remove lately. However, molecules with a larger size are retained from the entering the pore, so they will elute first, causing them to move with the mobile phase out of the column. That is the one which moves first. Sorry. Here the big blue particles will remove first because they don't have space to go into that spores. If the mobile phase used in an aqueous solution, the process is termed as gel filtration chromatography. If the mobile phase is used as an organic solvent, it is termed as gel permeation chromatography. Now we'll move on to high performance liquid chromatography. This is based on the principle of different absorption, where different molecules in a mixture have a varying degree of interactions with the absorbent present on the stationary phase. That is, the molecule having higher affinity remain absorbed for a longer time and decrease in their speed of movement through the column. So the molecules which have lower affinity will move faster and it will elute first. This process is slightly different from the column chromatography, as in this case the solvent is forced under high pressure of up to 400 atmospheres. So here also we use pressure to increase the affinity, increase the efficiency, and to decrease the turnaround time of the test. Here is the HPLC method. You can see the HPLC column. Before the HPLC column, there is a pump which we use to increase the pressure of the HPLC column and to increase the efficiency of the separation time. And hydrophobic interaction chromatography. This is based on the interaction between two molecules with hydrophobic groups. So the stationary phase is solid, supplied with both hydrophobic and hydrophilic groups. The solvent molecules containing hydrophobic regions interact with the hydrophobic groups, so the separating them from the molecules with hydrophilic groups. We use here the hydrophobic and the hydrophilic affinity of the analyte. The interaction is then reversed by applying the elution solution with the decrease in salt gradient. It will cause the molecules with hydrophobic groups to separate it from the stationary phase. Here the red color ones are hydrophobic ligands, and orange color one are the hydrophobic portion, and the hydrophilic portion is the blue color. So hydrophobic ligand will be bind with the hydrophobic portion, but the hydrophilic portion will not bind with the hydrophilic portion will not bind with the hydrophobic portion. So we can use salt solutions to elute these bounded substances. In ion exchange chromatography, this is based on the principle of attraction of charged resins and the oppositely charged analytes, that is, as I told, cation and anion exchange chromatography, similar to that. Here the exchange of negatively or positively charged ions takes place to remove the charged molecules. The stationary phase is first coated with the particular charges, where the components of the mixture will opposite charges will bound. Cation or anion exchange resin with the higher affinity to the charged components then binds the component, displacing the oppositely charged resin. This is the cation and anion exchange resin component complex. This is then removed by using the different buffers. Both the cation and the anion exchange chromatography are under the topic of anion. We can put those two under the topic of anion exchange chromatography. Here you can see we have here we have used the negatively charged anion to separate because the resin or the stationary phase is positively charged. Liquid chromatography. This is based on the principle for the affinity of the molecules to the mobile phase. If the components to be separated have a higher affinity to the mobile phase, the molecules move along with the mobile phase and come out of the column faster. So, if the components have a lower degree of interaction with the mobile phase, the molecules move slowly, so they will come out from the column lately. So, therefore, if two molecules in a mixture have different polarities, so there will be different interaction with the solid phase. So, they will elute in different times. It will take different times to elute from the stationary phase. It is called the liquid chromatography. This is the grammatic description of the liquid phase chromatography. We can combine it with the mass spectrometer to detect the analyte which are eluting from the liquid chromatography column. And last one is the paper chromatography. There are two types of paper chromatography. First one is the paper absorption chromatography. It is based on the varying degree of interaction between the molecules and the stationary phase. The molecules having higher affinity remain absorbed for a longer time, decreasing their speed of movement through the column. However, the molecules with lower affinity move faster movement. Therefore, it will allow molecules to be separated in different fractions. Second one is the paper partition chromatography. Moisture on the cellulose paper acts as a stationary phase for the molecules moving with the mobile phase. The separation of the molecules is therefore is based on how strongly they absorb into the stationary phase. In addition, additional concept of retention factor is applied during the separation of molecules in the paper chromatography. The retention value for the molecule is determined as the ratio of distance traveled by the molecule to the distance traveled by the mobile phase. The retention value of different molecules can be used to differentiate those molecules. This is paper chromatography description. Here we use the solvent and it will carry the molecules towards the upper part of the paper, and it depends on the affinity of the stationary phase. Reverse phase chromatography. This is based on the interaction between two molecules with hydrophobic groups. Here the stationary phase is solid, supported with both hydrophobic and the hydrophilic groups. The solvent molecules contained in hydrophobic regions interact with the hydrophobic groups, therefore it will help to separate them from the molecules with hydrophilic groups. The interaction is then reversed by applying an elution solution with decreasing salt gradient, which causes the molecules with hydrophobic groups to be separated from the stationary phase. Here we use hydrophobic groups as a ligand in the stationary phase. So hydrophobic red particles will be bind to the stationary phase, whereas the yellow hydrophilic groups will elute first. Then we can change the hydrophobic groups into hydrophilic nature, and then the hydrophobic groups which were bound to the hydrophobic stationary phase particles earlier will elute secondly. So we can select the hydrophilic solvent from the hydrophobic analytes. In thin layer chromatography, components of a mixture are separated when the component having an affinity towards the stationary phase binds to the stationary phase. In contrast, other components are eluted with the mobile phase. The substrate or the ligand is bind to the stationary phase so that the reactive site for the binding of components is exposed. The mixture is passed to the mobile phase where the components with binding sites for the substrate bind to the substrate on the stationary phase while the rest of the components are eluted out of the mobile phase. After separation, the molecules are seen as spots at different locations throughout the stationary phase. The detection of molecules is performed by various techniques. This is the thin layer chromatography. Thank you. Sorry.
Thank you, madam. We can entertain a few questions online if you have.
I'm not asking any questions from this. I want to know about the techniques you used in your laboratory because it was a metabolic lab, no? That is, you detected very rare diseases in UK.
Yes, madam. There is a metabolic lab, but it's not a major metabolic lab in UK.
So what were the techniques they used there to diagnose rare diseases using chromatography?
Gas chromatography with the mass spectrometry.
That is for organic acids.
Yeah.
HPLC also they did?
Yes, they use in that.
No one is using those old techniques, no paper, thin layer?
No, madam. They don't use that. They go through the gas chromatography and the HPLC with the mass spectrometry.
Okay. Good, good.
Thank you.
Okay, let me now invite Dr. Iresha Jasinghe to present the token of appreciation to Dr. D.N. Disanayaka. Senanayaka, sorry. Thank you, madam.
We have a special announcement again. The organizing committee has decided to have the raffle draw at 4 p.m. So we kindly invite you all to visit the virtual stores and complete your passports and be eligible for the raffle draw. Thank you. In our lineup, we have a lecture again on handling of samples with medico-legal importance by Dr. S.I. Majita, consultant chemical pathologist at Teaching Hospital Batticaloa. Over to you, madam.
Thank you. So, good morning to all of you. I am Dr. Majida, chemical pathologist from Teaching Hospital Batticaloa. The topic is handling of samples with medico-legal importance. In Sri Lanka, the medico-legal services are free and it's available in health sectors from district hospital to tertiary care hospitals. The medico-legal specimens refers to any material, could be a biologic or non-biologic, such as pills, capsules, or powders. This analyzed by laboratory as part of an investigative procedure, and the results and the report may be presented as evidence in a court of law. The specimen may undergo any diagnostic, clinical or anatomical studies, and the results of any of these studies is considered as evidence. Therefore, it is imperative to understand the medico-legal significance of certain clinical pathologic investigation and analysis. There are two percepts. The first one, you should aware that specimen have a medico-legal significance, and you should understand that specimen need a special handling. The second percept, we should understand the basic definition and terminology related to that investigations, such as medico-legal investigation, toxicology, specimen integrity, and chain of custody. The first thing is a medico-legal investigation. It's a type of examination that is designed to determine the manner of death and causes of death, illness, or injury. Under the toxicological investigation, there are three categories. One is investigation on biologic specimen, such as pills and capsules and powders. The second one is a forensic toxicology, where we are analyzing the biological specimen, the drugs in that biological specimens. That drug is caused death, or the drug is related with the sexual crime, and or serological studies. The third one is a clinical toxicology. We are analyzing in a biologic specimen for the therapeutic substances which is necessary for the diagnosis and treatment. The specimen integrity is the other terminology is related with the medico-legal specimen. It refers to its intrinsic property. That is, we have to be careful on specimen integrity throughout the process until the report is delivered, even after until the report is the analysis is done. That means that we can't change, or you can't make any change in the specimen integrity. We have to be very careful to make sure that there is no any adulteration in the specimen. So in order to preserve the integrity of the medico-legal specimen, the laboratory personnel should understand and aware about the method of collection, identification of the specimen, and the handling of the specimen. Therefore, you should take all the precautions to preserve the integrity of the specimen, because the medico-legal specimen is a physical evidence and it has an intrinsic credibility. So the credibility of the specimen is based on certain criteria. One is the reliability, skill, and knowledge of the person who is handling that sample. and the reliability of method used to detect the analytes in the laboratory, and reliability of the interpretation of the report, that is testimony related with the relationships of this report. That testimony, that report interpretation is going to the court and making decision from that, so that should be very reliable. If the reliability and the credibility of the specimen is impeached, if it is impeached by faulty origin of the specimen, faulty identification, and insecure custody of the specimen. Therefore, the entire testimony may be barred by confusion. So it can make a civil litigation to the people who are involved with this specimen and the analysis and the reporting. Those people can be a physician, pathologist, or laboratory personnel. So the causes for that impeachment can be due to a negligence, substandard handling, or improper testing, or improper reporting of the specimens. So such negligence can cause a loss of money or other injuries like physical and mental injury to the complaining party. Other one is the chain of custody. This is defined as a continuous process of the specimen. There are several people involved in the handling and processing and everything, and there should be a written record, should be maintained throughout the procedure. That is a chain of custody. The purpose of chain of custody is provide the following documentation. One is a specimen collection from the correct person, the specified laboratory performed the analysis, and the list of all persons who had involved with the specimen before analysis, and the name of the technology who performed the analysis. So, to prevent the adulteration of the sample, the collection of specimens should be witnessed. After that, the collection, it must be properly sealed and stored in a secure location until it is analyzed. The information required for the chain of custody procedure, there are several things, all are very important. Even if the one part is missing, then the chain of custody, maintenance of chain of custody is lost, then it will cause a big problem to the testimony. So there are several things. Out of that, the date and time of analysis and test results, the unit should be defined. You can't change the units, and the miscellaneous test performed during the to determine the adulteration of samples. The example, if they send it as a urine, it could be a water. So you have to make sure whether the sample is the urine. So you can do some other test to identify whether it is urine or not. So examples are urine specific gravity and urine creatinine. So because of the hours in Sri Lanka, though the medical legal services are free, but the laboratory doing the test is not well established, because we have several problems in the sample integrity, chain of custody maintenance, and analysis, the proper method of analysis to give the accurate results, and our laboratory is not set for that purposes. So we are dealing with the clinical samples. When it's become a medico-legal problem, this everything is very important. At the moment, we don't have such a laboratory, but the policy should be made by the hierarchy people with the discussion of colleges of pathologists, colleges of legal medicine, the Ministry of Health Ministry and the Justice Ministry to implement this good legal medicine laboratory in our country. So there are several conditions associated with potential medico-legal ramifications: motor vehicle crashes, sexual abuse, drug abuse, and so on. If we can make a decision, we are not taking any samples related with the medico-legal incidents. But you should remember there are some incidents. The clinical sample will come to your lab and we do the assessment, assays, and subsequently it become a legal significance. Such as you can tell an alcohol assay. So one example. Because of that, we can't say sometimes the clinical sample, even the clinical sample may undergo into the medico-legal potentials. So most commonly, we are getting for assays, the medico-legal purposes, the body fluids found at crime scenes are blood, semen, saliva, vaginal fluid, urine and sweat. So each body fluid have a unique composition. We using that principle to differentiate different fluids. So the pathologist must develop a strict guidelines for all laboratory technologists how to handle the legal samples with delegation of responsibility and the development standard operative procedures that all should be in writing. The pathologist should be informed immediately by a clinician or administrator, because if the pathologist is present at the time of sample reception, it allows the pathologist to personally involved in the supervision of the chain of custody and obtaining the specimen with the proper identification until it is analyzed. So the medico-legal samples are stored in a sealed container with the inappropriate preservatives. Before such samples are analyzed, the integrity of the seal must be carefully checked whether any adulteration is occurred to that sample. The results of biochemical analysis are difficult to interpret due to alteration in the blood after death. So there are some biochemical markers are there with a different stability in the post-mortem samples, such as some analytes are almost stable, like urea, protein, cholesterol, bilirubin. Some are elevated during agony period. Examples: creatinine, uric acid, gamma GT. But some of these analytes are elevated after death, that magnesium and myocardial markers. Some are decreasing after death, so sodium and chloride. And some are elevated during the after death, and there is a decrease but is a delayed. That is example is a calcium. So because of these changes in the biochemical markers, it is not feasible to apply pre-analytical analytical method used in clinical practice to post-mortem assays. The normal clinical sample, we know the pre-analytical analytical factors, what is the affecting the assays. But here, because of these changes in the stability, we can't apply those. So the postmortem analysis of chemical constituents of the blood is difficult if the blood is not taken immediately after death or before it gets coagulated. Therefore, the use of ocular fluid, that's a vitreous humor, is a useful medium to examine changes in the constituent. So we can use vitreous fluid for the detection of an analysis of potassium, alcohol, and glycemic substituents in glucose and HbA1c, those. So vitreous humus is preferred for post-mortem investigation because it's have a large volume and easily can access. The composition is more stable and less affected by the post-mortem changes compared to blood than CSF. Contain 99% of water and macromolecules. There are various electrolytes also can be measured in vitreous humor, such as sodium, potassium chloride, calcium, and magnesium. So from the vitreous humor, we can measure the post-mortem interval by measuring potassium in the vitreous humor, and I will explain in the about the post-mortem interval. Then some of the cause of death you can identify by doing some investigations on vitreous fluid, such as post-mortem identification, that's a body identification by DNA assays, virology by HIV antibodies, anti-HIV antibodies, anaphylactic shocks, beta tryptase, sudden infant deaths and time of death hypoxanthine, pregnancy, beta HCG, like that. So post-mortem interval is a time elapsed between death of a person and the time of autopsy. The estimation of time since death is a paramount medical legal issue in any post-mortem examination. By assaying the vitreous humor potassium, we can calculate the post-mortem interval in hours. That rough idea you can get with potassium by applying that potassium in the formula. So electrolyte disorders you can find diagnose by using a vitreous humor's sodium level. If it is greater than 155, we can tell there's evidence of dehydrations. But there are changes can occur in the post-mortem sodium level, but it's helpful compared to the blood sodium. The vitreous humor sodium is stable, so you can diagnose from that. So if you take a diabetes and alcoholic ketoacidosis, the postmortem diagnosis of hyperglycemia and ketosis can be achieved by biochemical analysis of vitreous humor. There are 3 substances to measure the ketoacidosis: acetone, acetoacetate, and beta-hydroxybutyrate. During ketoacidosis, hydroxybutyrate is found in highest concentration and seems to be the most specific postmortem marker of ketoacidosis. But beta-hydroxybutyrate alone, you can't distinguish between the diabetic ketoacidosis and alcohol ketoacidosis. In that case, you should measure the glucose level in the vitreous humor. But in vitreous humor, the glucose can used by the surviving hyelocytes and inner retinal cells during the early postmortem period, leading to a decrease in glucose concentration. But after their death, the equilibrium will be gradually take place between intra and extracellular space. So this drop in glucose concentration stops around 24 hours after death. Because of that, low vitreous glucose concentration is not synonymous with the hypoglycemia. However, when the blood glucose levels are abnormally high, not all the vitreous glucose will be metabolized, will not be metabolized. So the concentration of glucose in vitreous is about half of the concentration in blood. So as example, if you take vitreous fluid as a 10 millimole in the vitreous fluid, it means that is roughly as 26 millimole of glucose in the blood. So if the level is exceeding more than 10, you can diagnose there would be hypoglycemia. So the high VH glucose concentration in conjunction with the significant beta hydroxybutyrate can distinguish diabetic ketoacidosis from other ketoacidosis. The high glucose concentration also indicates that an individual was a possible diabetic that caused the death. So like vitreous humor, the semen can be another most important biological fluid come to the in helping to diagnosis. So there are several presumptive tests as well as confirmatory tests available to identify the semen. The most reliable one is the microscopic identification of the sperm. But the conditions such as patient already vasectomized or asuspermic males and in women who are sexually active. In those people, the sperm will last around 4 days. So with the multiple partners, you can't find out this sperm belongs to whom. In those type of situation, you can't go by a microscopic identification of sperm cells. In that case, we can do other popular accepted presumptive test is a seminal fluid acid phosphatase. But there are false positive with the seminal fluid acid phosphatase because some plant material contain that. Because most of the sexual crime happen in the jungle and the bushes, so that mixed with the plant material can mixed with, then that can give a false positive results. In that case, we can use the vaginal acid phosphatase also will be interfere with the seminal fluid acid phosphatase level. So in these cases, we can distinguish SAP and VAP by isoelectric focusing electrophoresis. And another disadvantage of SAP is this enzyme can degrade when exposed to heat and most of them putrefaction of the body, dead bodies. In these conditions, what is the other test for the diagnosed semen is a PSA. The semen from asuspermic males still contain that antigen. So that means in this situation, if the laboratory is not giving evidence of sperm, you can't come to a conclusion that the assault never took place. Otherwise, you can tell the error in the collection, processing and interpretation of the specimen. Those things you can you can suggest that those things happen to that sample, and because of that only you don't have that positive sperm and those things. But the assailant may be oligospermic, azoospermic, already done a vasectomy, or sexually dysfunctional during the assault or withdrew the penis before ejaculations. So in this type of situation, what is the other options? There are new advances in the pathology, and the laboratory medicine opens door for alternative demonstration of positive evidence indicative of sexual assault. These are the two newer techniques, FISH and the DNA fingerprinting. These two areas have taken us into a realm of science and technology that we never dreamed possible. Studies using above techniques have identified non-sperm cells from males. The ascending epithelial cells, inflammatory cells originating from the penis and genital tract, or cells from the hand, or cells from the mouth. This is especially important in cases of child sexual assault when the assault is digital or oral in nature. So other sample is a urine. You know that urine is contain urea and creatine in higher level, though you can tell that it is urine. But the specific immunological method is to tell is a TAM-Horst protein, but it is found in other animal species as well. So the most important common investigation is ethanol. Even in the medical purposes also they are measuring the ethanol, but sometimes it become a forensic and causing a problem for the most clinical laboratories. Example is a routine testing for alcohol following RTA, motoric offences. Many hospital and clinical laboratories don't have the resources to provide quality forensic testing for the ethanol. In that case, two-tiered protocol can be used. One is you have to clearly differentiate the case whether it is medical or medico-legal, potential medico-legal. If you think that sample or the case can become a medico-legal, in that case you have to take two samples. One is at the emergency department, sample taken by qualified personnel and transport immediately to the laboratory to start the treatment. That report should be entered in the LIS system and mentioning that test done only for the medical purposes. The second sample, preferably as a whole blood, collected by same personnel and using the chain of custody procedures, and the sample can be sent to a reference laboratory for forensic purposes. The ethanol test can be performed on different specimens, whole blood and plasma, serum and saliva. Usually the femoral blood is preferred to detect alcohol level in forensic cases, but if we can use vitreous humor or urine in a situation of stab injury, burns and severe hemorrhage. You can't get the blood in those cases. Because of the ethanol is volatile and specimens should be kept sealed, serum or plasma should be analyzed within 4 hours when collected under sterile condition without preservatives. If you want to keep the specimen for up to 2 days, you should collect the sample as a whole blood in sodium fluoride and potassium oxalate tube. Sometimes the ethanol can reduce or increase due to the fermentation, and so because of that we are using that preservatives. Sample may be stored indefinitely if you keep it is in -20 or lower. Normally the ethanol is distributed into the aqueous phase rather than the cellular phase of the blood. So the whole blood ethanol concentration is approximately 15% lower than the serum concentration. The serum to whole blood ratio is approximately 1.14. As a summary, in medico-legal sample handling, all precaution must be taken to safeguard the integrity of the specimen and its processing, since the medico-legal investigation and the specimens are legal matters. It is a time-consuming procedure and requires definite specificity of analysis. And the laboratory professional must be realized the advantages and disadvantages of each specimen type. Senior staff in the laboratory may be called upon either material witness to validate the results or expert witness to interpret the results. It is essential that they have confidence in the method that is used to analyze the assay, the specimen, and the staff performing the analysis. In all medical legal cases, only the physician or pathologist should be as an expert witness, may render an opinion regarding the interpretation of the results of the laboratory studies. These are the references I gone through to make this presentation. Thank you.
Thank you very much, madam. It was a very informative and interesting lecture. We gained a lot from that lecture. As we are out of time for the questions, I will call upon Dr. Kisali Hirimuthugoda to hand over the token of appreciation to the speaker. Our next speaker for today's program is Dr. Tatsarani Vitana Patirana, Consultant Chemical Pathologist at District General Hospital, Vaunia. Her speech will be on next generation sequencing techniques.
Thank you, Saraji, for your kind words of introduction. During next 30 minutes of time, I would like to talk about next generation sequencing techniques. First of all, I would say it is a very complex topic to discuss within 30 minutes of time. Because of that, I made this presentation as simple as possible. And I kindly request the audience who are expert in this area, please don't be get annoyed with this presentation. During my talk, I'll be talking about what is next generation sequencing, the evolution, potential uses of clinical practice, analytical process, methods available for NGS, advantages as well as disadvantages. So what is next generation sequencing? It is a technology which you can use to determine the nucleotide sequence of DNA or RNA. So initially it was called massively parallel sequencing. That is because it enables the sequencing of many DNA strands in multiple samples at the same time. So by using this NGS technology, you can analyze different types of genomic features from single nucleotide variants to copy number and structural variants and even RNA fusions in a single sequencing run. So regarding the evolution of NGS, it became available at the onset of 21st century. This great man who is Robert Holly, he's an American biochemist. He was the first man to sequence tRNA molecule in 1964. So about 13 years after this extraordinary man, who is Frederick Sanger, a British biochemist, developed the sequencing method for long DNA. Actually, the Sanger method, which is used in research laboratories at present also, use his method. So because of their extraordinary achievement in the field of genetics, they both won the Nobel Prize in 2 occasions. And this NGS system is introduced to commercial use in 2005. So let's see what are the potential uses in clinical practice. NGS gives us a lot of information which is helpful for diagnosing and understanding complex diseases. Out of them, it provides full or complete genome sequencing of an organism, analysis of epigenetic modifications, mitochondrial sequencing, genome sequencing, exome sequencing and transcriptome sequencing. By doing transcriptome sequencing, we can understand how altered expression of genetic variants affect an organism. Not only that, we can use it for sequencing of complementary DNA of diverse RNAs. Amplicon sequencing, it allows the detection of mutations at extremely low frequency levels. For example, identifying low frequency somatic mutations in cancer samples and discovery of rare variants in HIV infected patients. And again, metagenomic sequencing, it means by using NGS, we can sequence all the nucleic acid in clinical samples at very high depth. Very importantly, we use NGS in gene therapy nowadays by sequencing tumor genomes. So let's see what is the analytical process of NGS. So whatever the method, whatever the technology that you are using, NGS consists of 4 main steps: library preparation, clonal amplification, sequencing and data analysis. So let's see what is library preparation. So after DNA extraction from whatever the sample, the DNA sample is processed into relatively short double-stranded fragments. It means we are going to fragment the double-stranded DNA into short double-stranded fragments. So usually these fragments are short about 100 to 800 base pairs. So this fragmentation can be done using several mechanisms, physically or enzymatically, or even using ultrasound excitation. So then what we do is we ligate an adapter to this fragment. What is an adapter is that it is a short double-stranded DNA piece which is synthetically modified. And also these adapters have a unique molecular barcode. Because of that, we can mix different samples different sample and different sample together and sequence at the same time, which is called pooling or multiplexing. So this diagram shows you how we prepare DNA libraries. So this is your genomic DNA. So whatever the method, we fragment this DNA into double-stranded DNA fragments. So then what we do is this DNA fragment is ligated by an adapter. So this adapter is having two ends, blunt end and the sticky end. So blunt end is the end which goes and bind with the DNA fragment, and the sticky end, of course, it is synthetically modified. They remove the phosphate group from the third position and inserted by a hydroxyl group. So that is to prevent dimerization of these fragments. So then after library preparation, we do clonal amplification. That is to increase the signal that we can detect from each target during sequencing. Usually for clonal amplification, we use PCR technology. So usually we use 30 to 60 PCR cycles. Basically, there are two methods of PCR, emulsion PCR and bridge PCR. In emulsion PCR, we use beads, and this is your DNA fragments. And for this mixture, we put emulsion oil and the PCR mixture. So after that, it forms a microvell like this structure. So to say it is a productive microvell, you have to have a bead inside and the DNA fragment. Then we proceed this into PCR cycles, and ultimately you will get the clonal amplification like this. And bridge PCR, what we do is first we tag these fragments with primers, and then we allow this mixture to go through a flow cell. So this flow cell surface is coated with again primers which are complementary to the primers which is attached to these DNA strands. So then the free end also there is a primer attached. Then this primer is going and search for their complementary primer, and it forms a bridge-like structure on the cell surface. Then the PCR cycles continues and ultimately make the clonal amplification of these strands. So this is called bridge PCR because it forms a bridge-like structure on the flow cell. Then after clonal amplification, we do the sequencing. There are basically 4 sequencing chemistries. Whatever the chemistry method that we are using for sequencing, they use the principal sequencing by synthesis. It means once the complementary DNA strand is synthesized, the sequencing is being done. So the first method is pyrosequencing, which is used by Roche Technologies. So here, this is the DNA strands to be sequenced, and what we do is we put 4 nucleotides one at a time. So if the particular nucleotide is the complementary base for this strand, it produces a pyrophosphate ion. So this pyrophosphate is converted to ATP at the presence of ATP sulfurylase and adenosine. So this ATP acts as a cofactor for luciferase enzyme, and it converts luciferin into oxyluciferin and light. So we are going to measure this light by the detector. And the second method is semiconductor sequencing, which is used by Ion Torrent Technologies. So this is pretty much similar to the previous method. Again, we put 1 nucleotide at a time. So then with the attachment of the complementary base, there is a release of H+ ion. So this H+ is detected by the pH sensor. So this is the signal that we are detecting in this method. And the third method is sequencing by ligation or solid method. This is, of course, a little bit of a complex method. So here, this clonal amplification in this method, it uses emulsion amplification. Because of that, we have a bead here, and this is the adapter, and this is the sequence to be, this is the target sequence to be sequenced. So first of all, what we do, we attach a primer of a particular primer length. Let's say it's N. So we have 4 different types of probes, which each probe contain 8 bases, and first 2 bases are complementary to the target sequence, and 3 to 5 bases are degenerate, and 6 to 8 bases are inosine bases. So these 4 probes are tagged with 4 different types of fluorophores. So what we do is we hybridize this target sequence with this with these 4 different probes with the ligase enzyme. So then what happened? The complementary bases are going to attach to the target sequence, and target sequence, and after the attachment of particular probe, the fluorophore is going to release from the probe. So then we measure the emission of this fluorophore by a 4-colored imaging. Then after the completion of this target strand, so the extension product melt off. Then the second cycle starts. So during the second cycle, same thing happen except the primer length. So in the second cycle, the primer length is reduced by 1 base pair. So then there are about 4 to 5 cycles are going on, and with each cycle, the primer length is going to reduce. Because of this shortening of primer length, as well as we use 2 complementary bases in these probes, this method is highly accurate. They say that it has a 99.999% accuracy with the 6th primer. It means N-5. So this is the most accurate second generation platform, and it is inexpensive. But the main disadvantage is that read length is very short. Because of that, we cannot apply this method for many applications. So the 4th method is reversible terminator sequencing. This method is used in Illumina sequencing. Here, the DNA strands are attached to a glass surface, and then we attach a short primer at the top to the free end. Then we have 4 nucleotides which are attached with fluorophores in 4 different fluorophores. Then what we do is we mix this nucleotide in excess. So then during the washing, you have a washing step, and excess nucleotides are washed off, and then in the next step, these attached fluorophores are removed from the system. So then this fluorescence emission is measured as the signal. So this cycle is going on and on till the completion of the complementary strand. Then after sequencing, next step is data analysis. So NGS generates large quantities of complex data. So the data analysis is a very complex process, and there are a lot of softwares available worldwide, and the companies which have their own platforms, also they have their own softwares, but whatever the technology and whatever the instrument they are using, they share similar analysis pipeline and use common matrix to evaluate the quality of NGS data sets. So data analysis, of course, divided into 3 steps. primary analysis, secondary analysis, and tertiary analysis. During the primary analysis, what we do is we extract the raw signals from detectors and transform them into digital data. So it called base calls. Then after this conversion, what we do is secondary analysis. During secondary analysis, we filter and trim these data depending on the quality. Then what we do is we align this data with the reference genome. Then in the tertiary analysis, what we do is we interpret these results and extract meaningful information from the data. It means whether this variant is pathological, likely pathological, or variant of undetermined significance. Likewise, we have to extract the meaningful information from the data that we get from the NGS. So because of the complexity of data analysis and also associated algorithms, usually NGS data analysis is performed by bioinformatics specialists. As I mentioned previously, there are a lot of software software packages have been developed commercially worldwide, especially in USA, Australia, and the region of Europe. So the most important thing is if you make any changes to the bioinformatic pipeline, you have to do a verification study then and there to ensure the ongoing acceptable performance. Otherwise, the end results that you are getting from NGS process going to be erroneous. And regarding data retention, it should be done according to the departmental policy for storage and retention times. Little bit about quality control in NGS. So of course you have to use internal quality control. First, no template control. For that you can use water only sample, negative or normal control, and a positive control. A positive control should be a clinical sample and it should contain clinically significant variant that carries a large copy number variation. We use a large copy number variation, that is because you should detect this large copy number variation at the end of the process, otherwise your whole process might be erroneous. Then you have to maintain ongoing conformity. For that you have to participate in EQA programs. There are a lot of EQA programs available internationally, and you have to perform frequent internal audits, especially the vertical audit, to cover all the process and ensure ongoing conformity. And let's see what are the methods available for NGS. The developmental of automation. In 1986, USA announced the first semi-automated DNA sequencer. And just 1 year after, they introduced fully automated sequencer, and in 1996, they marketed the capillary sequencer. So regarding the generations of DNA sequencing, as I mentioned previously, Sanger method, which is developed by the Sanger, is the first generation technology, and it has a very good accuracy of 99.99%, and that is still the gold standard for clinical research sequencing. And newer methods we call next generation sequencing, and nowadays newer methods are very common because of their high throughput capabilities and lower cost per run. And this table shows you the different platforms available for sequencing: amplification method, sequencing chemistry, read length, sequencing speed per hour, maximum output per run, and the accuracy. So out of those platforms, the Illumina, Ion Torrent, and NanoPo are the very common sequencing platforms which are used nowadays in clinical practice as well as in research laboratories. So these platforms have their own advantages and disadvantages. So when you are selecting the platform, it should be according to expected size of the genome to be studied, its complexity and the depth of coverage, and also the accuracy needed. For example, for de novo genome sequencing, long read lengths may be appropriate. Likewise, you have to select the platform according to your requirement. The cost of DNA sequencing, according to National Human Genome Research Institute in USA, they said, according to their estimation, from 2007, the cost is dramatically reduced towards the year 2017. That is because of the competition between different platform providers, as well as the increased use of NGS technology in clinical practice as well as in clinical researchers. Little bit about third generation NGS. So in third generation NGS, they use single molecule for sequencing and single real-time sequencing, removing the need of clonal amplification. So in this third generation NGS, we don't have amplification step. So this reduces the errors caused by PCR, and it simplifies the library preparation. And again, it gives much higher read length during sequencing. So we have one platform with third generation NGS, which is Pacific Biosciences. So you can see in this table, the read length is very high. It is about 4,000 to 5,000 base pairs. So let's see what are the advantages and disadvantages. NGS offers ultra high throughput and speed, and it determines the order of nucleotides in entire genomes and provides comprehensive genomic coverage, highly sensitive in detecting low frequency variants, lower sample input requirements, significantly cheaper, more accurate and reliable. Not only that, we can use NGS for sequencing epigenetic modification, which is very important in the disease classifications. And there are a few disadvantages as well. For examples, for small scale experiments and for finishing regions cannot be easily sequenced by using NGS platforms. For that, we have to use Sanger sequencing. And as I mentioned earlier, sequencing NGS produces huge volume of data. So there may be many computational challenges associated with processing and storing of this data. And again, you might come across ethical issues regarding ownership of an individual's DNA when the DNA is sequenced. So these sequencing data must be stored very securely. Having said that, I'm going to finish my presentation. These are my references for my presentation. And I would like to thank the President of College of Chemical Pathologists and the council members for giving me this opportunity to talk about a timely topic. And again, I have to mention you all, we are going to implement a genetic laboratory in the government hospital setup at National Cancer Institute of Sri Lanka. So there we are going to implement NGS technology using Illumina system. In chemical pathology point of view, we are going to measure oncological genetic markers in liquid biopsies. So I think you can have hand-on experience about NGS system in near future. Thank you so much.
That's a very descriptive lecture. Thank you very much. The floor is open for questions now. In that case, I have one question to ask you. With regard to the sequencing methods, the Ion Torrent and the Illumina, the reversed one, is it the cost that we are referred to the most when we are picking in between those two, or is there anything else we should consider?
So that is, of course, it's not depending on the cost per se. So we have to decide what are the things that you have to do with this NGS. So first of all, sometimes they have their own menus. So sometimes some methods, they don't introduce our menus to their system, like let's say the open system and the closed system in a general biochemistry analyzer likewise. So Illumina system actually it's a very good system. That is because they allow us to introduce or include our customized panels.
Okay.
Let's say emerging markers, sometimes with the discovery of new markers, you have to introduce those markers for your panel as well. So in those instances, it is very important to have like customized panel remaining in your NGS system. Otherwise, you have to go for another technology. That's why that is not purely because of the cost.
Right. Thank you very much.
A very complex area which we don't understand, Salsarni, but you gave us some insight. It's good. It's good that somebody is going to start it in Sri Lanka.
Yes, madam. Actually, it was a very big task for me to make this lecture, and I have done a lot of work to make it more simple. Because I also know that it is very difficult to understand if somebody is not aware of this technology.
We are not aware really. Our knowledge is very, very at a low level. Good.
Okay, we can wind up now. Let me invite Dr. Iresha Jansinghe, consultant chemical pathologist, to present the token of appreciation to Dr. Tatsarni Vitana Patirana.
Okay, now let us break for lunch. Please join with us again at 1 p.m. Thank you.
world-class healthcare products and services. This prompted Emma Pharma to construct its business on the triad of our people, our partners, and our technology.
What do we know about the inside of a machine? And what do we know about the inside of a human body? What is hiding behind a diagnostics test? I'll tell you, more than you ever imagined. Think how complicated it is to replicate the same process that happens in nature. when a small molecule such as 125 vitamin D has to be identified among a million of the same molecules. You have to clone the 125 vitamin D receptor and send it on a hunt through plasma for its target, the 125 vitamin D. Once the target is identified, a very special monoclonal antibody has to be engineered with the ability to bind this 125 vitamin D with complex receptor. Just the complex receptor though, not the free-floating receptor. In order to achieve this, the understanding of biology is essential in reproducing what nature has mastered through millions of years of evolution.
world-class healthcare products and services. This prompted Emma Pharma to construct its business on the triad of our people, our partners, and our technology.
What do we know about the inside of a machine? And what do we know about the inside of a human body? What is hiding behind a diagnostics test? I'll tell you, more than you ever imagined. Think how complicated it is to replicate the same process that happens in nature when a small molecule such as 125 vitamin D has to be identified among a million of the same molecules. You have to clone the 125 vitamin D receptor and send it on a hunt through plasma for its target, the 125 vitamin D. Once the target is identified, a very special monoclonal antibody has to be engineered with the ability to bind this 125 vitamin D with complex receptor. Just the complex receptor though, not the free-floating receptor. In order to achieve this, the understanding of biology is essential in reproducing what nature has mastered through millions of years of evolution.
world-class healthcare products and services. This prompted Emma Pharma to construct its business on the triad of our people, our partners, and our technology.
We warmly welcome you back. Our next presentation is on renal function test by Dr. Niranjana Vitanage, consultant chemical pathologist at Sri Jayawardhanapura General Hospital. May I now invite Dr. Niranjana Vitanage to deliver her speech.
Thank you, Saraji. A very good afternoon to all, ladies and gentlemen. Today, now our topic is renal function test. As the name implies, it is about the kidney function. The global burden of kidney disease is huge, as you can see in 2017 data. So it's increasingly growing population of patients with kidney disease. Sri Lanka is not an exception, so we are in danger. So as laboratory people, we have a huge work to be done to assist the clinicians in the clinical management of kidney disease. Just look at this picture. It could be your sister, your daughter. So early detection of renal functional derangements is important in starting the proper appropriate treatment on time. So commencing treatment early will prevent the disease progression, and it will at least slow down the severity of the renal disease, which otherwise will lead to dialysis dependency, renal transplant, or all of them will lead to an early death. So today, it's a vast area. Today, at this time, for the next 30 minutes or so, we'll focus mainly, briefly, on functions of the kidney, derangement of kidney function, and biochemical investigations, mainly as creatinine. The kidneys are responsible for excretion of waste products and toxins. You may have seen a lot of abnormal reports of creatinine, urea, and uric acid, and it is also responsible for regulation of extracellular fluid volume, serum osmolality, and electrolyte concentrations. And it also produces, there are steps involving some of the hormonal pathways. So what is glomerular filtration? It is simply how urine is produced when blood is flown through the kidneys. In other words, is the physiological process of creating an ultrafiltrate of blood as it flows through the glomerular capillaries. So what is glomerular filtration rate? So it is how fast your kidneys filter the blood and produce your urine. This table shows that GFR differs with the sex, that is male to female, and with the age, the GFR is reducing. So you can't have a constant value. Other than age and sex, there are some other factors which causes the variability intra-individual and inter-individual wise in GFR. For example, exercise, pregnancy, time of the day, hyperglycemia, and so on. Other than the renal function derangements as acute kidney injury and chronic kidney disease. So what are the uses of renal function test? You can identify the presence of renal disease, and you can monitor the response to treatment once the treatment is started. And of course, you can determine the progression of renal disease, the rate of progression. So we can divide the biochemical tests of renal function into two main categories, as seen here: the measurement of renal glomerular function and measurement of renal tubular function. Sorry. So, in terms of kidney, there are two major areas we have to cover: the acute kidney injury and chronic kidney injury. Acute kidney injury is when, as the name implies, it's the acute insult to your kidney functions. So it's the acute decline in renal function leading to a rise in serum creatinine and or a fall in urine output. So there, our serum creatinine plays a major role. Other than that, venous blood gases, urinalysis, urine chemistries, and urine osmolality also plays a role in management, finding a cause, and monitoring the response. Second one is the chronic kidney disease, which is the most dangerous one. As the name implies, again, it is the presence of an abnormality in kidney structure or function persisting for more than 3 months. So these are the factors. May it be GFR less than 60 or albuminuria, abnormalities in urine sediments. So I would like to emphasize the importance of urinalysis in here, in your UFR. And renal tubular disorders, there are many tubular function tests and history of kidney transplantation for more than 3 months. Once you have diagnosed the chronic kidney disease, you have to stage your patient according to this chart from the level of GFR and urine albumin to creatinine ratio. Why we stage like this? The whole management and monitoring depends on these tests. Before moving in, we have the markers of kidney injury. They can be exogenous or endogenous. Exogenous filtration markers, I'm sure you all know, the gold standard of glomerular filtration, gold standard marker of glomerular filtration is inulin. And there are some alternatives: iothalamate, iohexol, EDTA, DTPA. Of course, often chelated to radioisotope with for the ease of detection. Even though we are not using it in our country, in other developed countries, these are freely available. From endogenous biomarkers, I would like to focus more on creatinine, which is a metabolite. So even though I have shown a lot of pack of functions of kidney, the GFR is the most important test of all in terms of rating the kidney in its function. So I will be dealing with GFR for the next few minutes. Measurement of GFR, for the ease of explaining, I have divided it into 3 categories: the blood levels of endogenous filtration markers, clearance tests, and eGFR. Blood levels of endogenous filtration markers, again, endogenous means it's produced inside your body. So serum creatinine is the major marker in here in our country. Cystatin C, not recently, but recently appeared marker, and there are many other markers which are emerging. What are the features of an ideal marker? It should be endogenously produced at a relatively fixed rate, freely filtered at the glomerulus, not secreted or reabsorbed by the tubules, and it should not have extrarenal elimination. But this is not a reality. We don't have an endogenous marker like this. That is why inulin has got the credit as an exogenous marker. So we'll move into our famous creatinine. It's a small molecule distributed in total body water, and it was first identified in 1847, and it was recognized as a filtration marker around after century. It was recognized as a filtration marker in 1926. So the advantages of serum creatinine measurement is, you know that the measuring is very easy, it's of very low cost, and there is widespread availability of assays even in our country. And disadvantages are, there are conditions, many conditions affecting its non-GFR determinants, and dietary meat intake or creatinine supplements increase the blood levels. These days, creatinine supplements are very common in younger population, so it can increase the serum creatinine level. Medications, some of the medications can inhibit creatinine secretion. This is not the interference of the assay. These medications directly inhibit creatinine secretions from the kidney, so that also a disadvantage. And recently they have found there is extrarenal clearance of serum creatinine, possibly by intestinal bacteria, which again kind of disqualifying creatinine as a biomarker. So it was 1886, Max Jaffe described this method, our Jaffe method, and this is the oldest clinical method still in use. In 1970s, the enzymatic assays appeared, and it was developing up to date. And in the background, the Jaffe method also improving with compensatory mechanisms added to the methods to reduce the interferences and other disqualifications for being a biomarker. Again, in 2005, a creatinine standardization program started. I think you all know, and it is a very big step in creatinine measurement to standardize all the creatinine methods, both Jaffe and enzymatic. So there are two major methods of measuring creatinine, Jaffe method and enzymatic method. Jaffe method, as we were discussing, it's not fully specific. There are many pseudochromogens, endogenous and exogenous, very commonly encountered in clinical practice. And it is also prone to other complex interactions also. However, as we discussed, for the past few years, there is a huge technical improvement in Jaffe assays. Enzymatic methods, there are many different and successive enzymatic reactions involved in different methods. Different platforms use different enzymes. So it varies from manufacturer to manufacturer. The analytical specificity and sensitivity of enzymatic assays are better than the Jaffe assays. That's why these days we are moving from Jaffe method to enzymatic methods in our platforms. So this is a brief list of interfering substances. You can see enzymatic method are better than Jaffe method. So the mass spectrometry, the isotope dilution mass spectrometry is recognized as the best method for creatinine measurement. So we use it as the reference measurement procedure. And all laboratories, the manufacturers standardize their creatinine assay to that measurement procedure. And all laboratories calibrate their creatinine assays against this calibration material provided by the manufacturers. However, still, Jaffe assays and some dry enzymatic methods still provide inaccurate results. Analyzing platforms in our laboratories use aqueous calibrators, which has different levels of interfering chromogens. So they have found in one study the biases can be between, up to 20% in between laboratories. And this is not commutable with our serum samples. So these factors limits transference of results between laboratories. So in my opinion, it is better to check delta in each and every test result for in-patient management, and always it's better to use one laboratory for one patient's follow-up. Otherwise, between laboratory variation also will add to the results and may give you a inaccurate impression on the progression of disease. And of course, you can, as a laboratory person, you can keep your quality standards up to the standard level, your internal quality controls and external quality controls. You have to enroll a good external quality control scheme and keep your quality standards up to the required standards. In that way, we can improve our laboratory results of creatinine. Just to show you that relationship between serum creatinine and GFR, you can see when the glomerular filtration rate is 40, which is very low, it shows around it shows a value around 200, which means it's not that. You may think that it's not very high, but when it passes 30-20 mark, it rises steeply to thousands and thousands. So serum creatinine per se, it's not a very good marker for chronic renal failure. Because of all these problems, people were looking for a better biomarker. The cystatin C is one of the promising one. It's again a small protein produced by all nucleated cells, freely filtered by glomeruli, but of course metabolized at PCT. It is less dependent on muscle mass, which is shown to be a better, which qualify is as a better marker than serum creatinine. However, it has its own disadvantages. As we discussed, it has less interferences. However, being an immunoassay, it has potential interferences which affect the immunoassays. It has shorter half-life, so it is very useful in critically ill patients because the renal function is changing very quickly, so you can detect it by cystatin C better than serum creatinine. However, it's more expensive, assays are not standardized, so there is a question of clinical benefit with routine testing. So there are other emerging serum and plasma markers. Just for the complete sake, I have mentioned here. And there are urinary biomarkers also. They say urinary biomarkers are better because you can detect the derangements of the renal function early, as the tubular cells are more in contact with urine and of course the glomerular cells, so it can detect early, but they are also emerging and in research level yet. So just an example, you can remember, now both these characters have serum creatinine level of 110. However, this thin character has GFR of 40 and this muscular character has a GFR of 120, where it is perfectly normal. So by serum creatinine only, we can't judge a patient's renal function, glomerular function rate. So because of that, people were looking for some other alternatives and they found clearance tests. So there are plasma clearance tests and urine clearance tests. Plasma clearance tests are not very frequently used in day-to-day practice, where you exogenously give a marker and measure the level of blood by serially taking blood. Sometimes it may drag for 24 hours depending on the GFR. Some of the patients prefer plasma clearance over urinary clearance just because of the inconvenience of collecting 24-hour urine sample. Urinary clearance is the common method we use. We measure the elimination of the marker from plasma by urinary excretion. There also you can use endogenous and exogenous markers, but we use the creatinine clearance most. I know that you got a nice lecture on 24-hour urine tests yesterday, so I won't be going into detail on this. But just to mention the disadvantage, just that you require a timed urine collection very accurately measured. And of course, we are the creatinine, the measurement of creatinine, the drawbacks of measurement of creatinine also applies here. So they are finding another alternative, the estimated GFR. GFR can be estimated from serum levels of endogenous filtration markers without requiring the process of clearance. So it is very easy in measurement. These equations are done from a regression equations that estimate the level of measured GFR after studying populations. These estimating equations provides a more accurate estimate of GFR than the plasma concentration alone. So these are the three formulas we know, and nowadays we use the chronic kidney disease epidemiology collaboration equation, which is CKD-EPI, which was done in 2009. As you can see, the CKD-EPI 2009 equation has 4 different categories according to the sex and serum creatinine levels. And also in 2012, they have found the CKD-EPI cystatin C equation, where they use serum cystatin C differently in male and the same equations can apply in male or female, but it differs with the cystatin C levels in the serum. And also they have found CKD-EPI 2012 creatinine cystatin C equation, where you need a very accurate idea of GFR. You can use this. It has 8 different equations to be applied in according to the sex and according to the level of serum creatinine, and of course according to the serum cystatin C levels. Here in Sri Lanka, of course, we are not frequently using these equations. There are limitations of the equation we are using, 2009 CKD-EPI creatinine equation, because all the limitations of creatinine measurement applies to this equation also, and they have not included the children less than 18 years old population into this study population, so we can't use it can only be used in adults more than 18 years, and racial differences may also exist. Any estimated GFR equation we cannot use in living kidney donation, where you need very accurate result, and in nephrotoxic chemotherapy, and when the GFR is not stable, as in acute kidney injury. So despite all of these considerations and caveats, serum creatinine remains the workhorse of eGFR determination in routine clinical medicine today, and will likely remain so for the foreseeable future. Thus, the major challenge for clinicians and laboratorians is to recognize the potential confounders of serum creatinine and when alternative measurement procedures might be used to better assess GFR. Just to show you how we should report the eGFR value in the lab, as we are using CKD EPI 2019 equation, we can use values up to 90 ml per minute per 1.73 square meter, but if or less. But if it is greater than that, we have to use greater than mark in front of 90 ml, and we are not issuing the exact value. And if GFR is greater than 90 ml, we have to use serum creatinine concentrations to check whether the kidney function is improving or the disease is progressing. And if the measurement there is a difference of 20% in the value, we can infer significant reduction in kidney function. So how are we going to monitor the chronic kidney disease and complications? It is again, we monitor by GFR and albuminuria. GFR mostly by estimated GFR, and albumin, urine albumin by albumin to creatinine ratio. Anemia by hemoglobin and iron studies. Why anemia? As I think you can remember, we discussed the erythropoietin is the pathway of producing erythropoietin has a part inside the kidney. So we are monitoring anemia by HB and iron studies in chronic renal failure patients. And of course, you have to monitor electrolytes, mineral and bone abnormalities. Why? Vitamin D, we discussed, is a function of the kidney. So these are my references, and thank you very much. And I take this opportunity to thank the President and the Council of College of Chemical Pathologists for giving me this opportunity to discuss on renal function tests.
Thank you very much, Madam. We have few questions they have asked. The first one is, is there a difference between 24-hour urine creatinine excretion and eGFR to confirm CKD? Whether there's a difference between the 24-hour urine creatinine excretion and eGFR in confirming CKD.
I think we discussed all the pros and cons of both methods, creatinine clearance and eGFR. I think that depends on clinicians' idea how to investigate and how to do the diagnosis on that patient. But for the diagnosis, in my opinion, I think it's better to have a creatinine clearance first. And then monitor with the eGFR value, because creatinine clearance is more accurate. But it depends on the clinical setting and the clinician.
Right. Thank you, Madam. And the other question is that when creatinine is the only analyte available for the detection of the kidney disease, I believe what the questioner is trying to say is that they do not have any other measures, maybe not even the eGFR, to detect the kidney disease. So how to overcome the fault results and interferences in creatinine measurements?
Well, it's quite a hypothetical situation because nowadays we have all the all the facilities to detect
Right.
kidney disease very well.
Yeah.
But still, I don't get the question.
Yeah, this is how she has asked how to overcome the any faulty results in creatinine measurement.
Yeah, I think that also we discussed.
Yeah.
We have to now all the platforms in nowadays are IDMS traceable.
Yeah.
So, however, it's better to use an enzymatic method which has very low, very less interferences. And in the laboratory, as the medical laboratory technologist, we have to make really we have to be careful on our quality standards, the internal quality controls and external quality controls. If all those things are okay, I think you can rely on your serum creatinine level. However, you can't diagnose with that serum creatinine level alone.
Yeah. Okay. The other question is that this they have received a sample which had traveled 2 hours, and then they have measured the creatinine level on that particular sample. The first value was 5.49, and then overnight, the following morning, I think the second value is 1.63. They say the QC is okay, with it's accurate. What are the possibilities? Can the creatinine level change overnight? That is his question.
It all depends how you have stored the sample. Ideally, you have to separate the serum sample and refrigerate.
Yeah.
However, it is better. It is always better to have a fresh blood sample and analyze. I don't know why they have first analyzed this date and then again analyze in the other day. However, it's always advisable to check the result as soon as possible. You have to separate the sample once the blood is get clotted nicely. You have to separate the serum sample, and as soon as possible you have to measure the serum creatinine level. That is that. Of course, there can be any interfering substances. As we discussed, there are a lot of interference substances for creatinine, so we don't know whether hemolysis is there or some other. And always it is better to analyze the serum creatinine in the blood sample as soon as possible.
Right. Thank you very much, madam. That's all the questions. Let's wind up now. May I now invite Dr. Deepani Sirivardhana, consultant chemical pathologist, to present the token of appreciation to Dr. Niranjana Vitanaga. Thank you, madam.
Next event in today's program is the quiz. May I now invite Dr. J.A.P. Sanjeevani, Dr. I.N. Jayasinghe, Dr. T.V. Manavadu, Senior Registrars in Chemical Pathology, to carry out this event.
Okay, the quiz will be conducted as an all virtual segment this time. So bear with us if you come across any technical difficulties. And let me brief you on how to join the quiz. There's a button on the bottom of the screen saying ask questions. You have to click on that. And then on the right hand side of the screen, you will see the join button, which you have to click on to join the quiz. So there are 20 questions. We will display the question and the responses on the right hand side of the screen. So then we will tell you the time when the time starts, and you will be given 2 minutes to answer the question, to choose the right answer and to submit the answer. And your answer will be recorded and analyzed instantly. And then we will tell you when the time stops, and we will discuss the answer for the question then and there. And after that, we'll move on to the next question. I hope it is clear to you. And at the end, 3 winners will be chosen, and the names will be announced later.
I wish you all the very best. Now let's get started. Your time is now. Your time is up now. Let's see the answers. Blood for PTH is collected into pre-chilled EDTA tubes. And for ACTH evaluation, we have to take blood into pre-chilled silicone glass tube or to a pre-chilled plastic EDTA tube. Because ACTH adsorb to the glass tubes, therefore we don't recommend glass tubes for ACTH
examination. Then for plasma renin, for direct renin examination, you can't take blood into in ice or in melting ice because it facilitates the conversion of free renin into renin and you get furiously high results. Then let's move into the second question. Now the second question is there, you can answer the question. Now your time is up. Let's discuss the question. There are various causes for falsely elevated potassium levels. Hemolysis, EDTA contamination, and refrigerated samples are one of them. Therefore, answer is wrong. After meal, insulin is secreted from the body, and that insulin facilitates influx of potassium into cells. Therefore, the answer is wrong there. And when you exercise, your muscles produce ammonia, and after exercises, muscles serum plasma ammonium get increased. Therefore, we ask patient to keep your arm rest before we take in blood for ammonia. Magnesium is an intracellular element like potassium. Magnesium also increase in hemolyzed sample. Now let's move into the next question. Let's see the answers. Bilirubin is the byproduct of hemoglobin metabolism. This bilirubin is bound to albumin and it's in unconjugated form and it is not water soluble. Therefore, unconjugated bilirubin is not present in urine. And we mention normal urobilinogen as in normal quantities. In our urine report, if it is normal, we mention it as urobilinogen present in normal amount. Negative urobilinogen is present in, we report in pathological conditions like obstructive liver diseases. Therefore, the answer is wrong. To see the deposit, we have to centrifuge the urine sample and we have to see the sediment. Therefore, answer D is also wrong. And we all know that ketone bodies are assessed by Rothera's test. Let's move into the question number 4 then. NB-BAPTA is a new method developed for detection of total calcium. It eliminates the drawbacks in evaluating calcium in low limit of the detection range. So, NB-BAPTA is for total calcium examination. And we all know that ionized calcium is the most common method for analyzing ionized calcium is ISC, and I know that you know that better than me for analyzing magnesium and phosphate, so I'm not going to discuss that. Let's move into the next question. Let's see the answers. According to the given case scenario, we can easily exclude acute kidney injury as creatinine level is between the normal range. And in case scenario, it is clearly given that full blood count is normal. In chronic renal failure, HB is low and also creatinine should be high if it is to become chronic renal failure. And in delayed separation of serum, potassium is not increased into this much. This is a very high value of potassium, 10.2 millimoles per liter. And this is a clear example of furiously high potassium in EDTA contaminated samples. Now let's move into question number 6. Let's see the answers. Dexamethasone doesn't interfere with cortisol assay. That's why we do overnight dexamethasone suppression test and also the high dose and low dose dexamethasone suppression test. Hydrocortisone and prednisolone are the two things that interfere with cortisol assay. It's true that in non-competitive assays we use two types of antibodies, and sometimes we call this as sandwich assays. And in response C also, it's true that in competitive assays, the analyte concentration is inversely proportionate to the signal generated. High dose hook effect and the prozone effects are two causes of low hormone concentration values. Let's move to the question number 7. up. TSH is the hormone we use to screen patients with hypothyroidism. It's not TSH and T4. We use TSH for screening for hypothyroidism. Therefore, the answer is right. Free T4 comes into an equilibrium before we measure that. It is the total T4 that change with the binding globulin. Therefore, the answer is wrong. Even your T4 level get normalized soon after treatment. It get about 6 weeks to normalize the TSH level. Therefore, the answer is wrong. It is not the alpha subunit. It's not the beta subunit, but the alpha subunit, which is similar with TSH, SCG, FSH, and LH hormones. Now let's move to the question number 8.
Answers. Okay. In this question, the serum protein electrophoresis, since the albumin is the smallest molecule, that is the one which travels faster, therefore it is far beyond the site of origin, and the serum is preferred because it doesn't have fibrinogen, as fibrinogen interferes with the banding pattern, and barbitone buffer is stored at in the refrigerator, therefore A, B, C are wrong, and the true answer is the silver stain, that is preferred stain used for CSF samples. Okay, then we'll move on to the next question. Your time starts now. on to the answers. In gas chromatography, usually we use an inert gas. The commonly used one is helium. And in the second statement, it says vitamin D measured by using non-competitive immunoassays. Usually it measures by using a competitive immunoassay. And pre-column derivatization is used in amino acid analysis by HPLC. That statement is wrong because what we usually do is post-column derivatization. And the statement D is the correct answer. That is the fecal immunochemical test for fecal local blood uses lateral immunochromatographic method. Okay. We'll move on to the next question. Your time starts now. Okay, that's the end of the given time. We'll move on to the answers. The phrase A says protein is a fast reactant in Jaffe method. Protein is a slow reactant, therefore phrase A is wrong. And compensated Jaffe method behaves in the same way for serum and urine analysis. That is also not correct because compensated Jaffe is used to eliminate the interference. So those interference are not in same compositions as serum and urine. Therefore the statement B is wrong. And statement D says bilirubin is a positive interferent with Jaffe reaction. That is also not correct since it's a negative interference. Therefore the correct answer is C. So results can be increased after a meal containing cooked meal. Okay, we'll move on to the next question. Your time starts now. Okay, that's the end of your given time. Let's move on to the answer. The colligative properties of a solution, there are basically 4 colligative properties. Those are freezing point, boiling point, vapor pressure, and osmotic pressure. What we usually get to measure the osmolality is a freezing point depression. Therefore, the correct answer is answer A. Okay, then we'll move on to the next question. Your time starts now. Your time is up. Let's move on to the answers. For urine pH analysis, usually you don't have to fill the tube fully. That is for the blood pH analysis. And the second statement says presence of air bubbles will increase PCO2 in the arterial blood gas analysis. Actually, it will decrease the PCO2 in the arterial blood gas analysis. And in the third statement, it says for 24-hour calcium estimation in urine, final pH of the sample should be alkaline. Actually, it should be acidic to dissolve the calcium phosphate deposition and the crystal formation. So therefore, the correct answer is D. Consuming vanilla containing fruit should be avoided when testing for 24-hour urine VMA. We'll move on to the next question. Your time starts now. Your time is up. Let's move on to the answers. It says regarding accreditation, which answer is false? ISO 15187, that is the false answer. Usually we have ISO 15189, and all the other statements are true. Participation in an EQA program is mandatory. Should have a documented procedure for reviewing non-conformities. Equipment must be operated by trained personnel at all times. So B, C, D statements are true, and the false statement is statement A. Okay. We'll move on to the next question. Your time starts now. Your time is up. Let's move on to the answers. According to the question, which of the following is true about calibration? Should be done daily for all analytes. That is wrong. You don't have to do calibration daily for all analytes. And the second statement says it is mandatory to be performed after a machine repair. It is not mandatory is wrong. And the statement D says an internal QC material can be used as a calibrator. An internal QC material can be used as a calibrator. It's false. It's false. And the correct answer is internal QC should be run after a calibration. So the correct answer is C. Okay. Let's move on to the next question. Your time starts now.
Your time is up. The question is, which of the following is false regarding quality control? QC material should be same as the matrix of the sample. That is correct. Special attention should be paid to the QC material than the sample. That is wrong, because you have to treat the QC material as same as the sample. Internal quality control measures precision. That is true. That's why we run it every day. And then Levy-Jennings chart helps to find systematic errors. That is also true. That also helps to find out random errors, but it helps to find systematic errors also. Okay, let's move on to the next question. Your time starts now. Your time is up. Let's look at the answers. Which one is correct regarding method validation? Let me stress on this. It's method validation. This is usually done by the manufacturer. So the first answer, performed ideally using 10 patient samples. That is wrong. You have to analyze 120 samples. Evaluating for accuracy and precision is enough. That is wrong, because you have to evaluate things like linearity, range, interference, recovery, LOD, LOQ, and specificity. Those parameters also should be checked during a validation. So that answer is wrong. D, evaluation should be completed within 1 day. That is wrong. Actually, ideally, it should be done over a span of at least 3 days. So the correct answer is the analyte concentration in the selected samples should cover the full measurement range. Answer is C. Let's move on to the next question. Question number 17. Your time is up. Which one of the following is true? AST is more specific to liver than ALT. That is wrong. ALT is the specific one to liver because AST is found in other tissues like skeletal muscle, cardiac tissue, red cells, likewise. So the response B, serum haptoglobin can be undetectable in intravascular hemolysis. That is true. Because when there's intravascular hemolysis, the free hemoglobin is bound to haptoglobin, and the haptoglobin and hemoglobin complex is excreted via urine, so that it will be rendered untoxic. So serum this response is true. Why why response C is incorrect is Foucher's reagent is used to detect bile acids in urine. Response D, increased unconjugated bilirubin is suggestive of obstructive jaundice. That is wrong. Increased unconjugated bilirubin is found in hemolysis. In obstructive jaundice, conjugated bilirubin is the fraction that is increased. So the answer is B. Let's move on to the question number 18. Your time is up. What is characteristically seen in OTC, ornithine transcarbamylase deficiency? Actually, OTC is another name for OTC deficiency is orotic aciduria. So if you know this, if you knew this, you don't have to know the other answers. The correct answer is A. Increased urine orotic acid excretion. So in OTC deficiency, plasma glutamine is increased, plasma ammonia is increased because these are urea cycle disorders. And as the name suggests, in OTC deficiency, the OTC enzyme activity in liver is decreased. So answer D is wrong. Let's move on to question number 19. Your time is up. Which of the following is false regarding biosafety? The answer is a biological safety cabinet must be present in the lab when using BSL2 materials. That is wrong, because only if you are doing procedures generating potential aerosols, for those procedures only you need a biosafety cabinet. Actually, biosafety level 2 laboratories are the primary diagnostic laboratories that you and I are working day to day. So for these laboratories, biosafety cabinet is not a must. So answer A is correct. Answer A is actually true. So in a BSL2 lab, the biohazard symbol must be posted on the door, and all items potentially contaminated with BSL2 materials must be autoclaved or chemically disinfected before they are disposed. And safety cups or sealed rotters must be used when centrifuging BSL2 materials, or you have to otherwise the centrifuge must be used inside a biosafety cabinet. So the correct answer is B. Let's move on to the next question. Your time is over. Question 20. Which of the following is false regarding tests used to evaluate for COVID-19? Answer A. Viral tests, nucleic acid or antigen detection tests are used to assess acute infection. That is correct. That is true. Then what I mean by nucleic acid tests are the PCR tests. So answer A is correct. Then a positive antibody test indicates past infection. That is also true. Then answer C, a negative antigen test result in a symptomatic patient excludes current infection. That is wrong, because antigen tests are less sensitive than the PCR test. So if when the patient is symptomatic, that is very suggestive of having a current infection. So you have to confirm the negative test by doing a PCR test. So this statement is false. Then pooling specimens in a testing methodology reduces test sensitivity. That is true. When you pool specimens together, if a few of the samples have low viral load, then it can dilute the other samples. So the sensitivity is going to decrease. So the correct answer for the question is C. That is the end of the quiz. Thank you all for joining.
Dr. Prabha, Dr. Tivanka, Dr. Imala for that wonderful session. Now may I invite Dr. Deepani Sirivardhana, consultant chemical pathologist, to present the tokens of appreciation to our senior registrars. May I now invite Dr. Sanjeevani to take the token of appreciation. May I now invite Dr. Tivanka to take the token of appreciation. May I now invite Dr. Imala to take the token of appreciation. Thank you, madam. It's time for a hot tea, to enjoy a hot tea. Please join with us again at 3 o'clock.
world-class healthcare products and services. This prompted Emma Pharma to construct its business on the triad of our people, our partners, and our technology.
What do we know about the inside of a machine? And what do we know about the inside of a human body? What is hiding behind a diagnostics test? I'll tell you, more than you ever imagined. Think how complicated it is to replicate the same process that happens in nature when a small molecule such as 125 vitamin D has to be identified among a million of the same molecules. You have to clone the 125 vitamin D receptor and send it on a hunt through plasma for its target, the 125 vitamin D. Once the target is identified, a very special monoclonal antibody has to be engineered with the ability to bind this 125 vitamin D with complex receptor. Just the complex receptor though, not the free-floating receptor. In order to achieve this, the understanding of biology is essential in reproducing what nature has mastered through millions of years of evolution.
Good afternoon, everybody.
Madams, I will introduce you first. Welcome back. Now, in our program, we have another eminent speaker to deliver her speech on lipid profile. May I now invite Dr. Chandrika Megama, consultant chemical pathologist and senior lecturer in pathology at Faculty of Medicine, Sir John Kotalawala Defence University, to deliver her speech.
Thank you for your introduction. Today I'm going to discuss about lipid profiles. So I think this is a very common investigation among the hospitals in Sri Lanka. So before I get on to the lipid profiles, let me describe what are lipoproteins. So cholesterol and triglycerides are, the cholesterol and triglycerides are insoluble in water. So when they are absorbed in the intestines, these lipid particles should be carried over to the other organs of the body. So therefore, they should become soluble. So therefore, they form a structure called lipoproteins. They connect with proteins to become soluble, and then they travel through blood to the other organs. So let's look at the structure of the lipid profile, lipoprotein. So as you can see here, there is a hydrophobic core inside the lipoprotein particle, which is water insoluble, and around it a surface monolayer of phospholipids and free cholesterol are present. And also on the surface of the lipoproteins, there are apolipoproteins. So this is the structure of a lipoprotein particle. So there are basically seven groups of lipoproteins, as you can see. So let's start from chylomicrons, which is the major lipid in chylomicrons is triglycerides, and the size is the largest. And then comes the chylomicron remnants. Remnants are like once the chylomicron is taken over to the periphery of the body, they are being hydrolyzed by lipoprotein lipase, and then the chylomicron remnants are formed at the periphery, and chylomicron remnants are rich in cholesterol than the chylomicrons. So then comes the VLDL. The main component of VLDL is triglycerides. And then IDL. IDL has equivocal triglycerides and cholesterols. Then LDL has mainly cholesterol. So HDL, cholesterol and phospholipids. And then very rarely we see lipoprotein little a, elevated lipoprotein little a of a patient. So that is also the main component is cholesterol. So as you can see in day-to-day language we call good cholesterol and bad cholesterol. So out of this, HDL is the good cholesterol, and the rest of it is considered bad cholesterol, and the triglycerides also play a role in ischemic heart disease. So as I explained the groups, now these lipoproteins were placed in a group, and the size of the lipoprotein is indirectly proportional to the density of the lipoproteins. If you look at this slide, how they are arranged as you can see in the y-axis you get the density, and the x-axis the diameter. As you can see here, the largest of the lipoproteins, as I said earlier, is the chylomicron remnants. As I said, the hydrolyzed chylomicrons, and then when you come down, you may see the size decreases, and at the same time, the density increases. So in other words, the density is indirectly proportional to the size of the lipoprotein. So as you can see, now here the pro-atherogenic lipoproteins are chylomicrons, VLDL, VLDL remnants, IDL, so and LDL mainly. They are pro-atherogenic lipoproteins. So then at the bottom you see the denser ones. They are the HDL2 and HDL3 subgroups. They are altogether anti-atherogenic. In other words, good cholesterol. So now we have come to the lipid profiles, which is the topic. So let's look at what is a lipid profile. Lipid profile is a panel of blood tests that serves as an initial broad medical screening tool for abnormalities in lipids such as cholesterol and triglycerides. Now, why is lipid analysis important? This lipid analysis is important because you can identify the patients who are at risk for coronary heart disease by doing the screen with lipid profile. And in other words, that is called dyslipidemia patients. The other benefit of doing lipid profile is once the patients are identified, they are put on anti-lipid drugs like statins, and then they should take lifelong statins after they are identified. So the monitoring is paramount important. So they have to be monitored regularly. So for that purpose also, while they are on statins, they have to go on doing lipid profiles at least once in 6 months to see whether they are being correctly maintain the lipid concentration. So this slide, I put the usual lipid profile. I think you all are very familiar with these reports. So you can see this lipid profile report. So you get 6 components in this lipid profile report: total cholesterol, triglycerides, HDL cholesterol, LDL cholesterol, non-HDL cholesterol, cholesterol to HDL ratio. So in the bottom you see the reference ranges which are given to interpret the test results. So let's go into detail about these lipid profile reports. So out of these 6 components, 3 components are directly done in the laboratory. 3 tests are done to find these 3 components. They are total cholesterol, total triglycerides, HDL cholesterol. So when you receive a sample in the laboratory, you centrifuge the sample and you get the serum, and then you mostly that now the labs are automated, so you put the sample in and then you select total cholesterol, total triglycerides, and HDL cholesterol. It's a matter of just selecting. And then you get the report for these 3 tests. So they are directly analyzed. So then once you analyze those 3 components, then these 3 are derived. Derived in the sense they are being calculated. So LDL cholesterol, which is the most important one, VLDL cholesterol, non-HDL cholesterol. Now this is recently added component non-HDL, and then you calculate the cholesterol to HDL ratio. So let's look at one by one how LDL cholesterol is calculated. Now actually in the analyzers, this formula, Fridwell formula, is included in the analyzer. So once you select the directly analyze cholesterol, triglycerides, and HDL, the machine analyzer itself has this formula. They have inserted the formula. We have inserted the formula. So then you get the LDL cholesterol by indirect method. It's called indirect method because it's been calculated. So let's look at this formula. So LDL is equal to total cholesterol minus HDL cholesterol minus triglycerides over 5 if the cholesterol, if the LDL cholesterol is calculated in milligrams per deciliter. But sorry, the triglycerides are in milligrams per deciliter. If the triglycerides are in millimoles per liter, you have to divide the triglycerides by 2.2. So let's see what is triglycerides over 5 or 2.2, what is it? So that is triglycerides over 5 or triglycerides over 2.2 is equal to the VLDL concentration. That is the second calculated component. So we will go back to the LDL cholesterol, and this calculated LDL cholesterol by Fridwell formula has its limitations. So what are the limitations? Now this calculation should not be used when the triglyceride concentration is over 400. And this cannot be used if the patient is non-fasting. Then you can't use this formula. And also in type 3 hyperlipoproteinemia. So type 3 hyperlipoproteinemia is one of the component of the hyperlipoproteinemia. In that you get equivocal elevations of cholesterol and triglycerides. Basically, they have near 400 or more than 400 triglycerides. So therefore, this formula cannot be applied. So when the LDL cholesterol cannot be calculated, LDL can be measured by using direct methods. So in our laboratories, in hospitals, we have direct measurement of cholesterol. So they are done by, once again, kids. Mostly in the analyzers, they use immunoturbidimetry method or antigen antibody. It's also immunoturbidimetry method, and it's based on antigen antibody reaction, and the concentration of the turbidity is directly proportional to the concentration of antibody antigen in the sample. So that is how we do the direct analysis of LDL cholesterol. So this I explained. Then the other component, calculated component, is the non-HDL cholesterol. So this is actually this talk about the non-HDL cholesterol came some times ago, some years ago. So the National Cholesterol Education Program revised the guidelines for lipids in the treatment of adults. So they found that now when you calculate the LDL cholesterol, now earlier they thought the LDL cholesterol is the best. And then subsequently with the increase of patients with metabolic syndrome and diabetes, they found sometimes this LDL cholesterol give a false value for the risk assessment, because now most of these patients, metabolic syndrome patients and diabetes patients, they have high triglycerides. And these high triglycerides interfere in the calculation of LDL cholesterol, and they give erroneous values. And they found, measured in the, calculating the non-HDL cholesterol is superior especially in metabolic syndrome and diabetes patient for the assessment of cardio risk. So now that is one advantage. So what is the other advantage of calculating non-HDL cholesterol over LDL cholesterol? Other advantage is non-HDL cholesterol incorporates all cholesterol in potentially atherogenic lipoprotein. Now, atherogenic lipoprotein particles, they contribute for the atherosclerosis in the blood vessels, which will lead to cardiovascular disease. So, therefore, this non-HDL cholesterol, now, if you do the LDL only, the only one atherogenic, you give the LDL cholesterol gives an impression about the risk. But here we have all the atherogenic particle. Now, if a patient is having very rarely increased lipoprotein little a, even this lipoprotein little a adds to the non-HDL cholesterol, and it gives a better idea about the atherogenicity of this patient. So that is the other advantage. And also the third advantage is you can do non-HDL cholesterol in a just non-fasting sample, because it's calculated simply by subtracting the HDL cholesterol from the total cholesterol. So you don't need fasting for total cholesterol or HDL cholesterol. So therefore, as the patient comes in, you can take a blood sample and do the non-HDL cholesterol. So it's very convenient for the patient. Now in other countries, now this is being practiced because they are not very happy with this fasting lipid profiles. So whatever the method you use, whatever the accurate method you use to analyze lipids in the laboratory, if you don't collect the sample properly for the lipid profile, then you will not get a better assessment. So it's very important to know about the sample collection for lipid profiles. So what are the factors you have to consider? Now I'm talking about the full lipid profile with the LDL cholesterol. Now, actually there are some points in this sample collection. One should take a normal balanced diet for at least 7 days prior to the test, and should fast for 12 hours. I'm talking about the full lipid profile. And then the patient preferably should be in a baseline stable condition. No point doing lipid profiles in a patient who got very acute infection, stroke, trauma, or any other pregnancy. It's no point doing the lipid profile. Now sometimes when the patient is admitted for some acute infection to the ward, the medical officer should, they just send lipid profiles, and then apparently we find those, apparently then when there's an acute infection, the lipids are suppressed, depressed actually. And you will find, and the other thing is, HDL is a negative acute phase reactant, and I had a patient with HDL of 5, because this patient had an acute infection, and the CRP was 325. And then when I repeated, when this patient went home, and when I repeated the CRP, when the CRP became normal, the HDL was 42. So you can imagine how, there is a big difference in doing lipid profiles in the stable condition and unstable condition. So apart from this usual lipid profile, there are ways of doing lipoprotein fractionation. Now this method, lipoprotein fractionations are used especially when there is increased chylomicrons in the blood sample, and also you can do in patients with normal chylomicrons as well. But then if there is normal chylomicrons, when there is a very easy method of doing things, now people don't do these investigations, advanced investigations. But when the sample is very turbid, you can't do this in the normal way of doing in the analyzer. So then you have to select some other ways of way of fractionating the lipoproteins. So one way of fractionation is the visual inspection. Visual inspection is you just take a sample, a fasting sample, and you keep the sample for 18 hours in the refrigerator, in the door of the refrigerator, and for 24 hours, and then you inspect the sample, and if the chylomicrons are elevated, you will see a creamy top layer, and the VLDL is elevated, you see a infranaate will be turbid. So by that, just a qualitative idea you can get of the lipoprotein particles. Then the electrophoresis, not a very advanced method, is a simple method, but hardly the electrophoresis are not done in Sri Lanka because you need apparatus and all that. So when there's an easy way of doing things, it's not really done. Now this is a electrophoresis, lipid electrophoresis, and see the chylomicrons, LDL, VLDL, HDL are separated. Like protein electrophoresis, it is done. So that is another way of separating. The other thing is the ultracentrifugation, which is the reference method of separating the lipoprotein fractions. As you can see on the right side, this is a sample after ultracentrifugation. This is how the lipoproteins will be arranged: chylomicrons, VLDLs, LDL, and HDL. So now out of these methods, visual method is very simple, and there is a relative accuracy in detecting chylomicrons. And then once again these lipoproteins separation by electrophoresis and and also there is another method here doing the fractionating lipoproteins by the size of the lipoprotein by electron microscopy. So that is very difficult. You should have an electron microscope for that. So it's expensive. So this is the ultracentrifugation, separation according to the density of the sample. So let's see what is ultracentrifugation. Now, as I said, the electrophoresis is of course a cheaper method and simpler method compared to ultracentrifugation, but the problem is the quantitative values are better in ultracentrifugation than the electrophoresis. Therefore, ultracentrifugation is the reference method, as I said earlier. So what is ultracentrifugation? Now, ultracentrifugation includes both equilibrium and rate methods after adjustment of the specimen density with salts such as sodium bromide or potassium bromide to float or sediment particles based on their hydrated density. So this is what is happening in ultracentrifugation, and you will get a picture like this on the right side. So all these are separated. So now we have gone through the lipid profile and how to, in additional, like in special methods of separation of lipoprotein fractions, and all this is done to detect hyperlipidemia. So what are the types of hyperlipidemia? Now, primary hyperlipidemias, they are divided to primary and secondary. Primary lipidemias basically divided into hypercholesteremia, hypertriglyceridemia, and combined hyperlipidemia. Secondary hyperlipidemias are hypercholesteremia and hypertriglyceridemia. So what is the difference between primary and secondary? Secondary is the patient has some other disease, and because of this disease, the patient get hypercholesteremia or hypertriglyceridemia. So examples for hypercholesteremia is hypothyroidism, obstructive liver disease, nephrotic syndrome, drugs, etc. So now let's say hypothyroidism. Why do they get hypercholesteremia? Because the hypothyroid patients doesn't have, the clearance is not done in hypothyroid patients, the cholesterol gets accumulated. Therefore, they get hypercholesteremia. So hypertriglyceridemia can be secondary to obesity, diabetes mellitus, pregnancy, etc. and the low HDL, that is also a dyslipidemia, by the way, and it is due to diabetes mellitus, rheumatoid arthritis, malnutrition, obesity, etc., etc. So what you have to remember is, now if you get a secondary hypercholesteremia, then no point treating hypercholesteremia straight away. If you give statins for patients with hypothyroidism, the cholesterol will get worse and the hypothyroidism will get even worse. So therefore, if you suspect of secondary hypercholesteremia, you have to always do the thyroid function test to exclude the primary disease. So I shall wind up with this case history. This is a lipid profile of a 48-year-old male who came for a routine checkup. As you can see, the test results show cholesterol of 315, the reference range is less than 200, triglycerides 250, less than 150 is the range, so there is hypertriglyceridemia, hypercholesteremia, and the HDL cholesterol, female, it's 35, it should be more than 50, and the LDL cholesterol is it's high. Now LDL cholesterol, we are not giving a range because it depends on the status of the patient. Then the non-HDL cholesterol is calculated, it's 280. Usually you interpret, now say the patient should have a LDL cholesterol of less than 100. Now in diabetics, the diabetic patient should have a LDL cholesterol of less than 100. So if the LDL cholesterol is less than 100, then the non-HDL cholesterol should be LDL cholesterol plus 30. So therefore, the non-HDL cholesterol should be less than 130. So that is how you interpret the non-HDL cholesterol reference range. And then the calculated ratio is quite high, it should be less than 5. So this patient has, I would say, combined hyperlipidemia with low HDL, which is a risk factor again, and with the increased ratio. So this patient is at risk of coronary heart disease and should be sent to treatment. So thank you.
Thank you very much, Madam, for that informative lecture. So if you have any questions, you can send us through the Q&A portal. As there are no questions, I would like to invite Dr. Gaya Katalanda on stage to hand over the token of appreciation to Dr. Chandrika Meegama. Thank you, Madam.
The last page for today's program is on common assay interferences encountered in chemical pathology by Dr. Tushari Vittanage, consultant chemical pathologist, teaching hospital Ratnapura. May I now invite Dr. Tushari Vittanage to deliver her speech.
Thank you, Saraji. Today my talk is on common assay interferences encountered in chemical pathology. Actually, interference is a substance or a process falsely alter the assay result. So it can lead to incorrect diagnosis and further unnecessary testing, and even it can lead to unfavorable treatment outcomes. So it is very important for us to know about the common interferences we encountered in the chemical pathology section. Interferences can be exogenous or endogenous, and it can be pre-analytical or analytical. When we consider endogenous interferences, these interferences naturally found in the patient sample, and it can be a natural substances or any other health related factor. So commonly encountered endogenous interferences are hemolysis, bilirubin, lipids, proteins, antibodies like autoantibodies, heterophile antibodies, and excessive analyte concentration, and cross-reacting substances like bicarbonate on chloride electrode when we use iron selective electrode, and ketones on Jaffe reaction measuring the serum creatinine. When we consider exogenous interferences, these substances are not naturally found in patient's samples, patient's body. They are added to patient's blood exogenously. These are including drugs. Drugs can be parent drug or metabolites or additives in the drugs, and poisons, herbal products, then IV fluids and substances we used as therapy. As examples, we use digibind in digoxin toxicity. Also, these exogenous interferences can arise from sample tube components and test sample additives like preservatives, and there can be exogenous interferences arising from the process of sampling. That means from the transport, storage, and centrifugation, like clots which occur in post-refrigeration in heparin plasma, and slow clotting serum, and carryover contamination, also exogenous interference. Here we discuss most commonly encountered endogenous interferences. These are hemolysis, lipemia, icterus, and paraproteins. When we consider hemolysis, it can change the analyte concentration or it can interfere in the analytical procedure. So when we consider change in the analyte concentration, red cells contain increased amounts of some substances, that means increased intracellular concentration. So when hemolysis occurred, that increased amounts of intracellular component can release into the sample, like potassium, AST, and LD. And it can cause, actually some components are in decreased amount in the red cells, so which it can cause decreased concentration because it causes the dilution effects when hemolysis occurred, like sodium and chloride. And hemoglobin has pseudoperoxidase activity, and it causes degradation of the bilirubin. Also, red cells has intracellular proteases which can degrade insulin and troponin 9. So these can change the analyte concentration. When we consider the hemoglobin, oxygenated hemoglobin absorbs between 320 to 450 nanometers, and deoxygenated hemoglobin absorb around 540 to 580 nanometers. So both their maximum absorption around 415. So colorimetric assays using this range of absorbance like iron, lipase, albumin and gamma glutamyl transferase, it can cause interference. And hemoglobin has alkaline denaturation effect. It can cause negative effect on absorptions of alkaline phosphatase. And it causes release of enzymes, RBC release enzyme like adenylate cyclase. It causes positive interference in creatinine kinase analysis. When we consider icterus, it can cause spectrophotometric or chemical interference. Bilirubin absorb between 400 to 540 nanometers and peak around 460 nanometers. So, colorimetric assays which take measurements at this wavelength, it can be affected, like phosphate and creatinine only by Jaffe reaction. So, other than that, bilirubin has an antioxidant property. It can react with peroxidase. So, hydrogen peroxide we use commonly in the clinical chemistry reactions. When we use hydrogen peroxide, that bilirubin can interfere with its antioxidant property like analytes, cholesterol, triglycerides, uric acid and enzymatic creatinine assay. Then, when we consider bilirubin, it can be conjugated or unconjugated. So, these have different effect on certain assays. Sometimes these can cause opposite direction interferences, like in Abbott Aeroset analyzer and Roche modular analyzer, triglyceride assays, there is a positive interference by unconjugated bilirubin and negative interference by conjugated bilirubin. Then we consider the lipemia. Causes of lipemia can be recent fatty meal, high intake of alcohol, diabetes mellitus, renal impairment, and total parenteral nutrition, and certain medications and hereditary conditions. Lipemia causes light scattering, and it can cause detrimental partition between the polar and non-polar phases of the sample. So, it can as well it can interact with lipoprotein particles and reagents. So, these three methods, it can interfere in the assay of our general biochemistry tests. Usually, light scattering occurs due to lipoprotein particles. Size of the lipoprotein particle may be different, so it can cause different degrees of light scattering. Chylomicron is the major cause of the light scattering, but other lipoproteins also can cause light scattering. Lipemia causes light scattering between the visual range, that means 300 to 700 nanometers, and it affects mainly in nephelometric and turbidimetric assays. But as in hemolysis and icterus, there is no specific peak for the scattering of light, but it increases as the wavelength of the light decreases. That means colorimetric assays, when we use between the around 320, it can commonly affect. Lipoprotein particles contain large lipid cores, so it can cause partitioning of the analytes between polar and non-polar phases of the sample. And it can chylomicrons tend to settle at the top of the sample if we left to stand it. So, it carries polar analytes with and it can affect steroid and hydrophobic drugs. But it will depends on the level of the analyzer probe aspirate the sample. Lipoproteins absorb hydrophobic reagents and can react with products and causing non-specific interferences in antigen-antibody binding in immunoassays. Lipemia causes negative interference in ceruloplasmin, creatinine, haptoglobulin, and prealbumin assays. When we consider paraproteinemia, it causes increased viscosity. So, increased viscosity causes difficulty in measuring the accurate sample volume. And this paraprotein can form complexes with creatinine kinase, lactate dehydrogenase, and amylase. So, these complexes cause microcomplexes. Form macrocomplexes. When we consider the interferences from the serum indices, that mean hemolysis, lipemia, and icterus, simplest approach is we are taking 3 bichromatic absorbances. So, there's an overlap between the spectral absorbance between hemolysis, lipemia, and icterus. We need correction calculations for that. So, as we initially mentioned that common interferences in the clinical chemistry, measurement of the serum indices, that means hemolysis, lipemia, and icterus also can have interferences. So that when we use correction equation, it will not account for the spectral overlap of the absorbance of the HIL index. Specimen which contain markedly elevated bilirubin or grossly hemolyzed samples shows non-specific lipemic plaques. And bilirubin concentration of 40 mg per deciliter cause negative interference in hemolysis index, and 500 mg per deciliter of intralipid has positive interference in hemolysis index. High lipemic index in samples with high immunoglobulins also. And other colored compounds we can found in the sample can interfere in the hemolysis, icterus, and lipemia index, like cross-Bengal, which is useful for treatment for melanoma. It causes positive interference in hemolysis index on some instruments, and patent blue V dye, it's used to identify sentinel lymph nodes, and it causes positive lipemic index and negative interference in hemolysis and icterus. High concentrations of EDTA cause positive interference in hemolysis index. There is an excellent correlation between the icteric index and bilirubin measurement. So we can think of there's interference in bilirubin or icterus measurement if there is a discrepancies between the icterus index and the bilirubin concentration. As an example, if there's a difference, we can suspect paraprotein interference in bilirubin measurement by DISO methods. But there is a looser connection between the lipemic index and triglyceride concentration because of variation of the number and size of the lipoprotein particles. So we should do basic test to perform the check and check accuracy and the precision of the hemolysis, lipemia, and icteric index. We can compare hemolytic and icteric index by measuring hemoglobin and bilirubin level. When we consider exogenous interferences, it can be drugs or it can be matrix effect or additives. When we consider drugs, it can react with reagents or analytes. Sometimes metabolites of the drugs also cause interference. Like here are some examples. Furosemide at normal doses, they do not interfere in Jaffe reaction, but in higher doses, it causes negative interference. And cefotaxime and cefoxitin cause positive interference in Jaffe reaction. And ascorbic acid causes negative interference in glucose oxidase method. When we consider additives, we use fluoride, in glucose tubes. So fluoride can interfere in many enzymatic assays. Matrix effect also cause non-linearity of the most biochemical assays. When we use non-commutable samples, it can also cause interference. According to CLSI interference testing in clinical chemistry guidelines, EP07, we can use two methods for the testing of the interferences. That means spike of normal samples and compare with non-spike samples. Also analysis of samples with both routine method and method. We know that interferences are not affected by that method. For the correction of interferences, we can use several methods. For the correction of chemical interferences, we can use removal of the interference by protein pre-sample, adsorption, liquid-liquid extraction, and also dilution. Also, we can use more specific chemical reaction like more specific enzyme reagents such as in glucose measurement, glucose oxidase or glucose hexokinase, for the urea, urease, and cholesterol, cholesterol esterase, and uric acid by uricase method. And we can use two-point kinetic reaction because many interference react at different rate than analyte. So we can choose optimal window for the kinetic reactions. Also, we can use some measures for the spectral interferences. We can use sample blank. That means sample absorbance is measured against sample blank, and colors due to sample can be eliminated from this method. And we can use bichromatic analysis. We use absorption maxima, and interferent will differ from that of the analytical reaction. So we can measure the both measurements at the specific ranges, and we can compare the absorbance of these two. We can use kinetic acid. So absorption reaction is measured at two specific different time points, and we can use initial reading. Almost all no colors has formed, and thereby giving the absorbance cause endogenous spectral interferent. And second reading we take after a short time, which include both original endogenous color and the color formed by the analytical reaction. So we can use the delta absorption causing the specific analytical reaction. Then we can use dilution, but we have to be cautious because over dilution can cause undesired effect. And there are instrument limitations. So for the instrument limitations, we can use these methods to remove those things because these things are inherent from the spectrophotometry. So at zero absorbance, photodetector receive most of the light signal. At any change in the absorbance, it will detect us at change in the percentage of these large amount of light reaching the detector. So if we think that absorbance is 2, only 1% of the light reaches the photodetector, and the same amount of the change in the absorbance will be reflected as large percentage of change in the light sector. To offset this problem, sensitivity of the instrument must be very high. So when we measure in the relatively high levels of analyte or interferent, there will be large spectrophotometric error. So especially when the instrument with low sensitivity. So to minimize this error, we can use a sample blank or sample dilution. Relationship between the absorbance and transmittance, I think you know it very well. So I included this one for the your refresh knowledge. And when we consider the interferences in immunoassays, most of the interferences in the immunoassays are complex and very difficult to resolve. Endogenous interferences, when we considered for the immunoassays, when we consider serum indices, there is no documented evidence of the interference by Icterus, and lipemia interference is confined to immunonephellometric or immunoturbidimetric assays. Hemolysis also can interfere, but we have to remember these can change according to the analyzer platform we use and the analyte we are measuring. So we have to go through the manufacturer's instructions and other things also. When we consider antibodies, usually these are polyclonal antibodies. They can interfere in most of the immunoassays. Autoantibodies in the autoimmune diseases like thyroid disease, and heterophile antibodies. Especially, it can affect two-site immunometric, that means sandwich assays, forming a bridge between capture and detection antibodies. And human anti-animal antibodies, especially human anti-mouse antibodies, also cause interference in immunoassays. Heterophile immunoglobulins develop as a result of treatment with drugs attached to mouse monoclonal antibodies or individuals exposed to mouse proteins. So farmers, university laboratory staff, and pet shop workers, even contacts at the household can have these antibodies. So we have to be careful with immunoassay of these patients. Rheumatoid factor also act as a heterophile antibody, and there can be a special interference, it called hook effect. It is due to excess antigen. In immunoassays, we have very wide range of measurement, but when the analyte concentration is very high, antigen excess result in falsely low values. Examples are myoglobulin, prolactin, HCG, and serum pre-light chains and urinary albumin. Other binding proteins like complement proteins and paraproteins are also capable of binding to assay antibodies and causing the interference. When we consider exogenous interferences, it can be tube components because we use different type of tubes. These tubes contain a different type of component, that means tube wall and additives if the tube top, and if we have any clot activated factors, gel tube, all these things can differently affect the immunoassay because it can cause different binding patterns in antibodies or analytes, and it can cause fibrin clots. If there is a fibrin clot, it also affects the immunoassays. We use monoclonal antibodies in cancer therapy. So these monoclonal antibodies also can interfere in the immunoassay. Like as I previously mentioned, autoimmune antibodies and heterophile antibodies interfere in the immunoassay. This also can affect. And like in digoxin toxicity, we use digibind. That digibind also act as an interference in the digoxin assay. In cortisol assay, there can be fluorocortisone derivative. These can be affect the cortisol assay. This is my interference references. So if you have any problem, you can.
Thank you very much for that very informative lecture.
If you have any problem now, you cannot understand or any problem, you can email me. My email address is here.
Yeah, y'all can email and ask for further clarifications. There's one question we have, whether we need to consider the lipemic property of a sample when doing CRP. She's asking like that. CRP, HbA1c assay, and And also must be asking about the nephelometric assays as well. Nephelometry.
Nephelometric assays, definitely it
Yeah.
can affect. And for the CRP also, because we use that binding antigen antibody.
Right.
And
Yeah.
both
HbA1c also she's asking, yeah.
HbA1c also,
So,
if the
yeah.
sample is live PME, it can affect, but actually I'll go through that one and I'll let email. Can I have her email address? So
Yeah,
that, I can
please
email.
forward your email address so that we can answer your question.
For the HbA1c.
Yes, okay. Right. In the absence of any other questions, I kindly invite Dr. Ajita Samarasinghe to hand over the token of appreciation to Dr. Tushari Vitanage. Thank you, madam.
Now we have reached the closing ceremony of the Medical Laboratory Science program. I cordially invite Dr. Ajita Samarasinghe, President, College of Chemical Pathologists, to deliver her vote of thanks. Over to you, madam.
With the conclusion of the last lecture, we conclude the second day of Medical Laboratory Sciences program and the academic 6th annual academic sessions MLS program. So on behalf of the College of Chemical Pathology Council, I thank all who joined with us today, and I hope the knowledge gathered from this program, you will be able to apply this knowledge in your laboratories. Since the other main academic program is running late, I invite you all to join the prize giving and the closing ceremony, I think around 4 o'clock. Thank you very much.
Thank you, madam. prize giving එකට join වෙන්න කිව්වා. හරි. ඔව් ඉවරයි.